recruited more nurses into the National Health Service, into the, so they are able to provide care. We are currently, we have very low numbers of healthcare workers. But like I said, we have to recognize the good work that is being done to address the situation. We know that nurses work under extremely difficult conditions sometimes. And we know that they are exposed to all these infectious diseases and figures speakers have alluded to. And therefore, we need to ensure that nurses are protected. We have protected first and foremost with the knowledge. And that can only come from training, from research, continuous research. But we have to make sure also that we have the equipment, we have the personal protective equipment, the PPE, that we use all the measures to protect ourselves while we care for our patients. That is extremely important. But nurses also play a critical role in research, and that research knowledge contributes to the development of new ideas in care and nursing, in health promotion, and that also reflects in good quality of care, in high standards. I want to take this opportunity to encourage all nurses to be proud of themselves. This is a noble profession. Honorable Minister, in conclusion, once again, I want to recognize the nurses and thank them for the hard work they're doing. And I urge all of them to continue supporting you. Thank you very much, Honorable Minister.
Thank you very much, sir. I want at this point to recognize our past Chief Nursing and Midwifery Officers of the Ministry of Health and Sanitation, Mrs. Nebekeru and Mrs. Osana Tukani. Can we give them a round of applause? I also want to recognize our program manager, one of the program managers, Minister of Health, who has and school and adolescent Madam Patricia Barr. And we give her a round of applause. We thank you, sir, for the encouraging words. Instead, we form the largest part of the health workforce. We are relevant globally. So therefore, we must be encouraged. That is a big one for us. And then instead, we can act in various capacities in the health sector. That I believe properly. Because when you have, I can remember when we had Betty, the president, as a human resource officer, he saw the improvement in that area. So thank you, sir, for reminding us. But remember, UHC, what is UHC? Universal health coverage cannot be achieved without you standing up. So therefore, let's put on our belts and get up and ensure that this country achieves UHC. Thank you very much. Now I will call on our dynamic acting chief medical officer to make a short statement.
Thank you very much, Madam Chair. The Honorable Minister of Health and Sanitation, Dr. Austin Bentley, the WHO representative in Sierra Leone,
the president of the Sigma group, the president of the Postgraduate College of Nursing, the president or representative of the West African College of Nursing. Allow me to stand on existing. I say good morning. Whenever I face the nursing, I always say, on behalf of the people of this country, I do apologize because we have not been treated. Why did I say that? We see people with 5 watts, and when they go for further studies, they come out with degrees. It is only in this country that nurses have the same qualification and come out with the certificate. We really need to change that. As we move or as we position ourselves as a country and as a ministry to really further with our dream, as we say, we want to address healthcare delivery using a universal health coverage, child leaving no one behind, using the primary health care as the wheel or the trail. But the reality is nurses are very important for us to achieve this. And you have been trying your best. We can improve the healthcare delivery or the system on the 3 fronts. One, using the service delivery, which we have really been paying too much attention to. The second one is acquisition of knowledge, academia. And then, of course, through research. You cannot divide the 2 or differentiate, the 3 or differentiate them. They can go inside them. But in the past, focus a lot on service delivery. Of course, don't misquote me. If you learn a lot and if you research a lot, it is only going to be beneficial if you put it in practice. Because the patients we serve do not want to know how qualified you are, do not want to know if you are a professor or not. What they care is, did you help in really reducing pain? So as we are striving and as we are pushing, and as I'm very happy that we're really taking a new form in addressing the issues of nurses in this country, we have to start thinking of how do we address some key things in this country. Our indicators, our process indicators are exceptional. Still attendance are bad. We are high up there, not so. Delivery in health facility, it is very, very high. But when we come to our impact and our outcome indicators, they are still very, very, very poor. And these 2 do not match. And that is where I see the research very important. We need to know the reason. We need to have the answer. Why are we doing so much? But then our results are still not that good. Focusing on infectious diseases and the challenges, I believe as you've been providing services before, there are a lot of bottlenecks. There are a lot of questions in your mind already that you may want to answer. I know today a lot of discussions, we'll make a lot of points to come out, but then you also have a lot in your mind that you want answered. So going forward, let's make it deliberate so that we'll have answers for those ones as we go before. At this junction, I will want to bring to your notice some few things. Maybe in the long run, we want to know why Sierra Leone specific or in Africa specific, COVID behaved the way it behaved compared to China, compared to USA, compared to other countries, or even within Africa. Why was it so serious in South Africa, in the northern part? We need answers that will help us to move forward. Why are we doing a lot of ANC? Our ANC coverage is exceptionally high, but then yet still, we still have pregnancy-induced hypertension, the second leading killer in maternal death. So as we move forward, let's think through, let's discuss, and come up with tangible points that we can help the ministry plan. And don't forget, we will look forward to have some of these recommendations 2 weeks from now in our headquarters. I want to thank you very much, and I wish you success.
Thank you very much, sir. Let's give him a round of applause. Reminded of us of three big things: service delivery, knowledge, and research. These are triplets together, so we impact on the service delivery at the service delivery point. The patient, he said, is not interested in what degree you have. All they are interested in to have a nurse at the bedside. So we say, here. Our indicators, he said, must match with our input and our output and the outcome. So he recommends that we have to invest in research to know why we are not taking that pattern in Sierra Leone. I want to thank you, sir, and God bless you. Now, we are coming to the most important part in our opening today, the keynote address. So I'd like to call on Mrs. Patricia Bath to introduce our keynote speaker for today. Patricia, please.
Madam Chairman, permit me to stand on the existing protocol and introduce our keynote speaker, with no other person but our Honorable Minister of Health and Sanitation, Dr. Austin Dendy. Dr. Dendy has served as the Acting Director of Office of Global Health at the U.S. Health Resources and Services Administration. He began his public health career in 1980 as a research scientist with the Center for Disease Control and Prevention, CDC. He then went on to become country director of the CDC station in Sierra Leone in 1987 to 1989. Where he studied Lassa fever and other viral hemorrhagic fevers. He has held research appointments at several institutions, including Special Pathogen Branch, Viral Reference Laboratory, Central Public Health Laboratory Service in the United Kingdom. In 1990 to 1993, Division of Pathology, Center for Applied Microbiology and Research, Portsdown, United Kingdom. In 1993-1994, Special Pathogen Branch, BVRB, NCIB, 1994 to 1997, and Diagnostic Microbiology, CNB, that's BASPLR, these are all abbreviations, colleagues, in 1998-1999. Following his work in microbiology research, Dr. Dendi became a founding member of CDC Global AIDS Program that between 1990 to 2006, he led several teams that established that program offices in Ethiopia, Rwanda, Tanzania, Zambia, and the Democratic Republic of Congo between 2006 to 2011. Dr. Asab, as director of CDC Malawi program, oversees the HIV/AIDS prevention, treatment, and care activities of CDC, and facilitating other major programs funded through 2 U.S. health agencies in Malawi. Distinguished ladies and gentlemen, colleagues all, in 2014 to 2015, Dr. played a key leadership role in the U.S. government's response to Ebola outbreak in West Africa. He was the first official from the United States government to conduct a rapid technical assessment of the institution in Sierra Leone and to sound the alarm to the global community. Dr. Dendi played 5 times in various capacities in Sierra Leone. Dr. Dendi holds a doctorate degree in clinical microbiology from the University of London, England, a master's degree in public health epidemiology / biostatistics from the University of Michigan, and a Bachelor of Science degree with honors from Kwame College, University of Leone. Ladies and gentlemen, we are privileged to have a researcher with us as the Minister of Health and Sanitation to come and deliver the keynote address for the very first time in the history of our profession.
Thank you very much, Madam Madam Chair Lady. Fantastic to be my neighbor. I see her first thing in the morning before going to my office, and I see her the last thing when I'm leaving the office every day. It's a real joy to be working with CNMO, incredible as she is, and I'm full of. I want to stand on existing protocols, Madam Chair, but I'll have to recognize the WR, Hongwei, who has been an incredible partner of ours in our quest to modernize healthcare in Sierra Leone. I want to acknowledge and recognize Java for an incredible role in postgraduate training for nurses and midwives in this country. I want to acknowledge the Chief Medical Officer, acting, Dr. Kenneth, a strong partner, and as you see, believes in nursing and nursing care. The Chief Nursing and Midwifery Officer, who always draws my presence when she's in the middle of these nurses. They love her to death, Nathan Fuller and Madam Bori. And I also want to take this opportunity to thank the Sigma Theta Tau International Organization, as well as the Delta Zeta chapter here in Sierra Leone and in Africa. This is a very important moment for me personally and for Sierra Leone in particular. I wanted to come and talk to you, and I had prepared notes, but I really don't want to use prepared notes here. I'm talking family. I'm talking to friends. I'm talking to colleagues that are going to transform the healthcare system in this country. And I can't do anything but start by saying thank you. Thank you to you, the nurses, who put your lives on the line every day to save lives. On behalf of the people of Sierra Leone, on behalf of His Excellency the President, I really want to say a big, big, big thank you. Could we give a big round of applause for our nurses in the world? As previous speakers have indicated, we are, the World Health Organization, which is a member state driven organization. We all own WHO. It's the Ministry of Health Ministry of Health. And the world got together and said 2020 is the year of the nurse. So we're all getting ready. I wasn't that we're all getting ready, preparing for the year of the nurse to be as fulfilling, as impactful, a whole year's event until it was interrupted by COVID-19. But we're not going to stop. As soon as this COVID is over, we're going to revisit that and acknowledge our We've been talking about universal health coverage. It might sound like a slogan, but for us in Sierra Leone, universal health coverage means something to us. It means that we want to have a high quality healthcare system where no one is left behind. Where we pay attention to everybody within this country, all 7.5, 8 million people. How do you envision that? We envision that through the life stages. First, starting with a pregnant woman. If you have a pregnant woman in this country, it's the nation's pregnancy. We're going to do everything in our power to ensure that you have a safe delivery of that pregnancy in our country. When that baby is born, we are no longer going to be bothered about the baby surviving. We want that baby to thrive. When that baby is thriving, we want to prepare that baby so that when they go to kindergarten, they're as healthy as they could be. When they're in kindergarten, they're ready to go to school, to primary school, that all of their health needs are being met while they're in primary school. Their cognitive behavior, their intellectual readiness, their nutritional status, their health status is all addressed. Till they go to secondary school, till they go to university, till they become adults, till they become senior citizens. That is the life cycle of healthcare. And at every nexus point, you have major health interventions that need to take place to ensure that people have access, that people ensure the quality, and they have assurance of better health outcomes. That is our interpretation of universal healthcare. If you look at that life cycle from pregnancy to senior citizens, who is left behind? If we do it right, nobody is left behind. Because we want to be sure that every aspect of it is addressed all along the way. Now, we're never going to do that effectively without competent, without able, without committed nurses and midwives. And so that's why universal health coverage is only going to be successful with the backbone of nurses and midwives driving our culture. So again, I want to take thank you for it, but also say our mission is huge. The responsibility is really critical, and without you, none of this is going to happen. So we as a government, and together with our development partners, and the regulatory institutions, and authorities and pretenders around us, we want to be the wind that's in your sail. We want to be the support group that allows you to thrive, to function at the very, very best. You know one of the things I like about nurses and midwives in this country and all over the world? They wear a uniform. Yeah? That uniform identifies. That uniform indicates dignity, respect, and professionalism. So you can't hide anywhere. Anywhere you go, they'll recognize that's the midwife, that's the nurse. What that does is give incredible power and authority. The issue now becomes, how do you use that power and authority? What we're looking at is patient-centered care. All of our work revolves around how do we support the patient. Nobody's going to go to the hospital for party, to go out and hang out and have fun. People go to the hospital when they need help. People go to the hospital when they're traumatized, or their relatives or their loved ones. And you go there, and when they go there, they expect service. And they are calm. They feel better when you see those uniforms, when you see those professionals. And for those that are doing that very well, we say thank you very, very much. At the same time, we know that we need additional support. We're going to do everything we can to ensure that those uniforms have within them the people that are going to do the work well. So training, acquiring knowledge, acquiring professionalism, providing the tools that will allow you to do this work is my responsibility, is the minister's responsible responsibility, and we're going to partner with you to make that. I think it's really important that as we take on this new role, like a new that we take this responsibility very, very seriously. The respect and the honor that is bestowed on you as the arbiters, as the caretakers, as the loving, as the caring, as the professional person that's going to take care of people's health. That focuses on patients, of clients at the center of the universe. We want that to be taken very seriously. I think the reality of it is we have to always constantly remind ourselves that words are something, but our actions are something else. And the outcome of those actions are really, really important. You know, the best measure of a good nurse in a hospital is one of the measures is your supervisor saying you're doing really well. You get an extra belt, get an extra medal, and we say thank you very much. But one of the biggest accolades you could ever get is what the public feels of you and your service. What that patient who comes in crying, moaning, and their relatives come in, they're helpless, they're literally in very, very difficult circumstances. The ambulance comes in, the ambulance is not coming for a party, the sirens are blaring, they rush in there. What they want to see, somebody in uniform who is out of the way. We're here, we're professional, we will take care, you are covered. I think when you do that well, when the patient recovers, you want anybody who is coming there crying to leave there laughing. You want anybody who comes in there in pain to live there thinking that, oh my God, we had incredible nurses there who took care of us. Even when you lose the patient, if you do a good job, somebody will say, we lost the patient, but they did their very best. That is my today. And most of the nurses are doing a brilliant, brilliant job. Again, I say thank you. I don't know how many times you've said today, but I want to say thank you again. So mind you, there's some people who are bringing the profession down. There's some people who are bringing the profession down. We should not let them do that to us. Supervisors, you shouldn't be in a room where somebody in a uniform is doing something wrong and you don't say something about it. We need to win back the confidence of the people. We need to win back their respect and their regard. And a lot of you, most of you in this room, and all of you in this room are doing your part to best. But people who are not doing that, they work together. Either educate them or ask them to listen. Because you don't want them there. No. So the government has started to give you a lot of input staff. One of the biggest struggles we have in the hospital setting, you don't want to have a two-tier system where And so we're working hard. We just got about 1,000 new pin codes offered to us in ministry. And come November, we will have another 1,000. And next year we'll have another 1,000. So we have about 3,000 pin codes that will come. I'm sad to say, happy to say, a lot of people with pin codes are doing it very, very bad. But there are lots of people with pin codes who are not at the work site when the inspection goes on. That's not fair. That's not right. You cannot have a pin code and you're not in charge and you're supposed to 10 nurses active with pin code and you don't show up, not one person is there. You know, if a patient dies at night when they're supposed to have 10 people who are there and only one person is there, that's murder. So it's not that, oh, you know, I need to go take care of people. You know, convenience thing. That convenience is actually money. We went to one of the hospitals the other day, there's 75 nurses on active duty. When we went there, 20 of them were out, not on site. Without anybody knows where they are. In a lot of cases, they're working elsewhere and making money elsewhere. At the same time, they're collecting money from the government to be at the work site. That is not right. That is not fair. That is not the profession that we are looking for. So we should not let that happen on our watch. So I'm advocating for all of the matrons, all of the supervisors, to pay particular attention to this, actually move towards mental health coverage. Actually move, if it's been happening in the past, it's been happening in the past. There's a lot we could do about fixing that. So going forward, we want this nimble, this dynamic, this forward-looking, this forward-leaning profession, this professional who are delivering service for them. Now, one of the really exciting things about this is we're no longer in a situation where people are satisfied with their basic nursing degree. And with the help of the NMO and the government and our partners, you have an opportunity now to not only have a bachelor's degree, you have a master's degree, you can even have a PhD in your nursing specialty. And what we're looking at is not only basic nursing care. Now, we're looking at specialist nursing in specialist areas. We're not only doing that now, we're looking at building new hospitals for you. Big hospitals where all your skills and talent will be included. So it's an opportunity. It's an opportunity for us nurses to really double our efforts as the backbone, as the heartbeat of the Ministry of Health, as the heartbeat of the healthcare system in the country. The cool thing about all this is now we are in a situation where this is 2022. We're going forward. We can no longer rely on expert opinion on things. We want data. We want evidence. We want to be able to understand why things are happening. We have to think critically. We have to ask questions. Where are these babies dying on my watch? And in the past, what happens is people just recorded 15 dead, 20 dead, and whatever misses, and gather reports and send it to headquarters. Headquarters report it out. Well, no. We're in a different category now. We're in a different group where if you count the number of deaths, why is it happening on my watch? What could I have done differently? And you start asking these important interrogative questions. How could we do things better? How could we improve health outcomes? So it's not just a process, meeting, conference, hearsay, yes, whatever it's not. We're beginning to interrogate the data that we generate and ask fundamental questions about how could we do this better? That is why research is so important. Research is question and answer. You ask the question, why are things happening the way they are? You interrogate the data, you collect the data, interrogate the data, and you bring solutions to it. And what we're going to be doing is to look at what are the health outcomes after you discover this. For example, let's take maternal mortality. We have, unfortunately, one of the highest maternal mortality rates in the world. We have one of the highest infant mortality rates in the world. We've done a lot to change that. We've done a lot to reduce the maternal mortality and infant mortality. But these are very modest changes. What we're asking of you now, of all of us as a nation, with our development process, is how do we radically bend this curve? How do we radically change these health outcomes? So, for example, now we have 717 maternal deaths per 100,000 lives. With a marketing original 1,300. So it's coming down. We want to challenge it over the next few years. We want to bring it down to less than 300. Is that possible? So I'll tell you something. The continent is moving. The continent is moving in an incredible speed. And Sierra Leone has always been at the very top of things. We had war, we had conflict, and we lost our ground. We lost our control as well. We want to regain it. And when we regain it, we're not going to regain it in gradual changes. We're going to regain it in radical quantum leaps going forward. So our colleagues in Rwanda had a similar problem. They had maternal mortality at about 650,000. In just a few years, they brought it down to 200 per 100,000. This is not Europe. This is not America. This is in Africa. It's possible. People are doing that. So I remember we invited the guy who headed the program to come up to the US and give a talk to Americans and how Rwanda. And at the end of his presentation, everybody stood up and gave him a round of applause. And he came back to the mic and said, why are you applauding? We brought it down from 850 to 200. No, we want to bring it to under 70 per 100,000, which is the WHO guidance. So I'm just, just hoping that I could inspire all of us. It's not a complaint. I'm hoping that I could inspire us as a family, as a nation, to be ambitious, to bring down maternal mortality in this country. And we can do it. We can do it today, do it today with an incredible workforce that we have. So I'll end up by again just reiterating the notion of innovation. The answer to innovation in your workplace does not have to come from your building. We're far removed from the action. You are on the front line. You are there seeing patients on a daily basis. You are the ones that come up with solutions, innovation, new ideas, new ways of doing business. You could say, you know what? When I worked in Pujao, this is what we saw. And you know what? This is what we did about it and changed the health outcome. We want that lesson that's learned in the proverbial Pujao to be something that everybody else will hear about and adjust in their own way. Or somebody who did some incredible work in Kabbalah, or somebody who did some incredible work in Kano. Let's learn from each other and bring all of these innovative new ideas to the forefront. Now we could teach the world, we could teach the other how to do this better, but we also teach the world as to how to do it better. So I'll end up by saying you are health workers, important, incredible health workers, but you also health diplomats. You health diplomats because your person represents the health sector. You are the first encounter with the public. If they have a bad experience with you, it rubs on the whole industry, the whole health sector. If they have a great experience with you, it rubs on all of us. I believe that we could be incredible health ambassadors, we could be incredible health providers, we could be the vanguard for universal health coverage, we could be the ones that will make the difference here in the health sector. We want you to walk out of here when you do a great job, walking down the street, somebody comes to I'm in North Side. I'm in Midcon Land. I'm in North Dakota. And guess what? If we're able to achieve that, we get thank you very much. So on that note, I believe that you're going to have an incredible conference. You're going to have some incredible questions that you're going to research questions that you're going to develop. You're going to organize yourself into answering these questions, and the whole nation holding their breath. See you and the work that you do in the meeting. This is an important meeting, and I look forward to the end result. And I'm very, very pleased. The first annual International Nursery Conference 2022 on the theme of the infectious disease, health challenges and personalized.
Occasion. Yes, I'm proud to be an No, we don't, but we just close up and we allow the ministers to lead because they have an important affairs to attend to. And I just want to tell you that he's counting on us and that we have the political support to improve or nothing into their youth. Thank you, Mr. Minister, for giving us that. Now, I think we can allow him to leave. Let's stand and usher him out. Go for tea break, please. So after. Thank you very much, everybody. Can we please take our seat? We are going to have a presentation from. I don't want to go. Yes. Or do you want to go on this first? Let's have the one is. Let's vote. How many people want to do it now? One. Thank you. So we have 30 minutes.
Hello?
Yeah, Ibrahim, we have Jennifer Harris Henry on and Dr. Bula. Welcome, Dr. Bula, all the way from Malawi, is on our Zoom.
Yeah,
Yes, I'm just sharing the program with everyone.
Hello, can I kindly have your attention? Can we kindly say that people will be called on because we don't want to have chaos.
Hello?
And remember, we're also mindful of COVID and precautions. So can we kindly say that people
Hello? Hello?
Okay, Ibrahim. So everybody, I just want to introduce our cameraman for the day is Mr. Ibrahim Jallo. Dr. Bula, I want to let you know this young man right here, our very first induction of Christiana Masaleh, Mary Makofula, and Betty Lamont, he's the person who recorded when I inducted them in February of 2020. He was the very first person. He's been there from the very beginning. So this gentleman traveled 3 hours away just to do this Zoom so SLNA members can watch it. We're going live stream on YouTube. And Dr. Bula, I just want to thank you for making this possible. The support of the African region. Dr. Bula, we also have Jennifer Harris Henry, who is on the call right now. She is a one of our lead members and officers from an organization called Qaeda 5. And they are planning to come into Africa too also. So I just want to thank everybody. I know you're joining 5 o'clock in the morning in the United States. You all who are live on the ground. I just want to thank you all for making this possible. Dr. Bula, thank you for your support. Jennifer, Dr. Agatha Bula, she's our actual Sigma Africa region coordinator. She's responsible for the whole continent. So Dr. Bula, I really want to thank you for joining our Zoom. This is the Sierra Leone Nurses Association Zoom. I'm the founder for the New York Tri-State chapter from 2008, and I'm also the one who helped bring Sigma. I brought it into Sierra Leone. So we currently have 117 members. Unfortunately, I wasn't able to be there. I had some emergencies with my son, but this is historic. We have never done this in the history of Sierra Leone, a research conference. Never like this, never. So this is our very first time. It's nurse-led, but we invited doctors, pharmacists, we invited everybody to come. So everybody on this line is a stakeholder into what we're trying to do for healthcare in Africa. And we really look forward to working with you. We're excited. We hope for our next research conference. I personally invite you to Sierra Leone, you, Wanda, all the leaders in Sigma. So I really, really want to thank you. This is historic for our country. And so you're going to see a wonderful presentation today on viral hemorrhagic fevers, on Marburg, on Lassa, on Ebola. You're going to see an amazing presentation on maternal morbidity and mortality. And you're going to see a great presentation on malaria and pregnancy. Wanda and I and Dr. Claudette Gordon, let's not exclude her, and Dr. Campbell have been working tirelessly for this conference. Wanda and I put it in our heads to plan it last year, August, September, and we made it happen. I want to thank the mayor of Freetown, Mayor Yvonne Aki Sawyer, because Mayor Yvonne Aki Sawyer is the one who I reached out to for us to use the venue. I want to thank her, all her staff that made it happen. I want to thank Sierra Leone Nurses Association on the ground, who is supported and helped us. I want to thank my dear friend, Dr. Austin Demby, the Minister of Health, for making this possible. There's so many people that added to this, and it's going to be an all-day event. I want to recognize my nursing students that we invited 10 nursing students from all over the country. We have nursing students who came all the way from McKinney, from EBK University. We have nursing students who came from Waterloo. We have nursing students who came from Lumgay, and we have nursing students from all over the country in Jala and Comas. So I really want to thank you all. I want to thank Ibrahim especially for traveling 3 hours just to make sure we're able to view this live. And thank you so much. So Ibrahim, when the program starts again, you can return back to the stage. Thank you so much, guys. And share it. We're live. We're on YouTube Live. We're streaming live on YouTube. It's on Facebook now. Everybody can watch it. I see the auditorium is full. This auditorium is the Freetown City Council auditorium. It's oversaw by Mayor Yvonne Akisoy Bomi. It's a 500 seat capacity. As Ibrahim showed you, we almost filled this whole venue. Thank you to all our sponsors. Thank you to Partners in Health. Thank you to Vicky Reed, the Director of Nursing in Connaught. She sponsored the Matrix Boston Nurses. Thank you to Christiana Bondi. Thank you to Jennifer Harris Henry, the head of the Jennifer Harris Initiative. Thank you to Dr. Gordon. Thank you to Sia Kabudu. Thank you to Abal Jawandos Sise. Thank you to the SLNA members who supported me. Thank you to Wanda Gordon for supporting all our students. There's so many people to thank. Thank you to my mother. Thank you to my father. There's so many people. But this is a time for Sierra Leone to uplift themselves, to uplift the healthcare profession. This is what we're doing, and the nurses have to lead first. And so I want to thank everybody just for your support. So I'll turn it back to Ibrahim. Ibrahim will turn it back to the stage when he returns. As you all can see, these are some of our nursing students that we have attending the conference. I'm just going to share. I hope you all on YouTube and Facebook can see us live on the net. These are some of the students coming from EBK. We want to thank the head of nursing, Evelyn Bangura, for she put out of the entire university, she picked these 5 students to come all the way from McKinney. And some of our more students, we have some others who came from Lungay and Freetown. We're thanking them all. They're all coming in one by one, but thank you. And this is the venue, just the aerial view of it. And thank everyone. Please, we really, really thank you. Good morning. Who's this? Good morning.
It's Sambo.
Hi, Sambo.
Hi,
How are
Zion.
Good morning. They're in intermission break right now. When they come back to the research conference, they're going to turn the camera back on for Zoom.
Okay, thank you.
You're welcome. How are you? How's it going? How's the baby? How's work?
Everything is good, thank God.
Amen. Thank God we're alive, right?
Yes.
Amen. Amen. So enjoy the conference. Share it with people in nursing that you know. Let them get on.
Okay.
This is a time. Any Sierra Leonean nurse that you know, or doctor that you know, or pharmacist or physician, let them get on the Zoom and enjoy the Zoom. This is for us. This is the first time we've ever done something, a research conference like this in the country. So this is a big day. And SLNA helped coordinate this.
Okay.
SLNA New York specifically is the one who coordinates this. They're doing it right now in City Hall at City Council.
Yeah.
Oh, right now we have Dr. Agatha Bula, who is the Africa region, Sigma's Africa region coordinator. She's joining the SLNA Zoom. She's joining in with us right now. So this is Dr. Bula. Just people went off because they're taking breaks during the intermission. And Africa, we got to save the battery and everything that's going on. Dr. Bula, this is one of the young ladies who came in our association who was started as a CNA and now she is a registered nurse. And so this is Dr. Agatha Bula. She's tuning in from Malawi right now.
Okay.
Thank you so much. Dr. Bula, thank you. Oh my God. Thank you so much.
Thank you.
Yes, thank you so much. We're really excited. We're really excited to have you on with us all the way from Malawi. When Wanda told me that you were going to join, I apologize that the Sigma is having some challenges with their Zoom over there. But for my backup, I had my own my nurses association because I'm the founder of the Sierra Leone Nurse Association, the New York chapter. I founded it in 2008, and so my chapter has actually like the one who's really push the different SLNAs from in the diaspora to come together. And so our SLNA, the background of our SLNA while they're on break, let me just tell you about them. The Sierra Leone Nurse Association was established in Sierra Leone, March 23rd, 1961. Let me take off camera so I can be a little respectful. March 23rd, 1961 in Sierra Leone. We are actually older than the independence of Sierra Leone. We have from my records last time, we had like over 600 members, but it grows all the time. We're affiliated with all the schools in the country. And so in 2007, we established the Sierra Leone Nurse Association chapter in California. And our founder is Abdul Koroma. Then we founded the SLNA chapter here in New York in 2008. We established a Jersey chapter, a DC, Maryland, Virginia chapter, a Texas chapter, and then we were trying to get Ohio and Georgia, and we currently have a Minnesota chapter and a North America chapter. So what we do as organizations here in the diaspora is we connect, how we do as Africans, try to give back. We medical missions, medical supplies, volunteer at hospitals, and we also do our own community work here. So SLNA in New York, we used to do health fairs, flu screenings, vaccinations. We, help route people to appropriate care, housing issues, immigration issues, people who are undocumented, because, especially living in the United States, we have a large population of Africans, and the largest concentration is in New York. And to be the Bronx specifically is the largest African community in the United States. And we were started in the Bronx. And so we've been here, and we're known with the mayors, the various mayors of New York City, the various senators and city council, and United States Congress has recognized us. And so over the years, all of us, we all have our own initiatives and regions that we work in and programs that we do. We have nurses who build churches, mosques, build schools, done everything, and we're there to support Africa. And so SLNA, we just don't work with the Sierra Leone community. We work with everyone. We work with outside the Sierra Leone community. We work with the immigrant community here in New York. All Africans, just people who are in need, underserved communities. And so Sigma, I've been a member since 2015. I was originally invited in 2000. Wanda brought me in, invited me again in 2015 in grad school. And from there, we just started to flourish. And, you know, I've been on the United Nations calls, and I know their discussion and talk about how to help start dealing with sub-Saharan Africa. And so that's a lot of our work, our passion. And you know, as a fellow African, you know, Africa needs some more attention. And so the actual Minister of Health now is a friend of mine, Dr. Austin Demby. The person who allowed us to use the venue, the mayor, she's a friend too, Mayor Yvonne Aki Sawyer. And you know, we have so many people who are looking forward to having you come to Sierra Leone. So I really personally invite you. I look forward to having you come. I think there's a lot of things that we can do in collaboration with Sigma, in collaboration with Malawi. And this is just the beginning. I think there's a lot of people who we know that through nursing and through social media and technology, this kind of exposure is good for Africa, it's good for healthcare, and it's good for especially the nursing profession. So I'm really honored that you got on and you spoke today. We are really honored that you got on both Zooms. And we really look forward to working with all the nursing organizations who really want to come and support our healthcare community. And when Ibrahim gets off the break, he's going to get back on and have the camera on Zoom for you all to enjoy. So what I coordinated was it's an all-day event. I planned it so that people could have breakfast in the morning, and we want to recognize Partners of Health. Partners of Health, Vicki Reed, the director of nursing from Kono, she's a Sigma member. So she got Partners in Health to pay for all the breakfast for the event. She was willing to even get them to try to sponsor the venue. And so she's one of our biggest supporters from Sigma. She's a member out of Georgia. And we have some other Sigma members in Sierra Leone who are members from Australia, members from another chapter, Rugi Bao, who's from Epsilon Mu. We have Sia Katubu, who's she signed in for the view. She's a Sigma member from I think Canyon University. So we have a lot of people we have Dr. Joan Shepherd, who's a professor in Sierra Leone. She's a Sigma member from Australia. And so we have a lot of people they were excited when they heard Sigma came to Sierra Leone. And, you know, it wasn't an easy process, but it's worth it when it comes to Africa. So we can't wait to have you come. I won't talk too much. I will put myself back on mute because I know we're going to start the program shortly again.
Yeah.
And,
so where are you based?
So I'm bicontinental now. So since last year, I decided I relocated back to Sierra Leone. I had to come to the States. Yes.
Okay, I see.
I
Yeah,
came.
so the other interest I have is, we are having these conferences as chapters. Is there any way we can, we can have a regional conference? But now the issue is sponsorship. And the other thing is, I can see, I think Sierra Leone are doing a lot. And it would be nice at some point to be having, exchange programs between chapters, which might help to learn from others.
Yes. I think, Dr. Bulla, we have 54 African countries. Mm-hmm. Out of that, we have Nigeria, Ghana, Malawi, South Africa, and Sierra Leone. Mm-hmm. So we have 49 other countries to encourage to establish a chapter. But before we even get to do that, we, the 5 countries, need to get together and have one word, as we say, and say, let's do a continent conference. And my suggestion is we should rotate, aside from this chapter doing this, I think we need to think large scale, because I think we'll be able to pull more people. I think the Africa region, we need to get together, 5 of us, and have a continent conference, which is dedicated to us. We can rotate our 5 countries. Sierra Leone came first. When we launched the African Continent Conference, we hosted in Malawi, then we hosted in Nigeria. Oh, we have Ghana too. So we have 6 continents, right? 6 countries. We can host it in Ghana, then we can host it in Nigeria, then we can go to South Africa. But it's for us, it's tailored for people who need to learn about Africa, know what's going on in Africa, and need to get exposed to what we're doing, not only the challenges, but the triumphs. Africa, I don't think anybody can touch us when it comes to brain and science. No. So I think we need to figure out a way to highlight it. I think Sigmund gives us that platform where we say, and thank God you're your coordinator for the continent. Say, hey, now reach out to each chapter chairperson.
Yeah, that's what I've started. Yeah.
And let's have one conversation.
I've gotten responses from other chapters where I'll be able to attend their monthly meetings, but the others haven't yet responded, because I think we have 6 chapters in Africa.
Yeah.
So currently I'm able to contact with the your chapter. There's another one, and then I belong to Kaizai. So I've been attending the meetings for Kaizai chapter, but the others will invite me soon. So I think we can discuss more as we go along on how best, we can work as a team, how best we can organize these conferences. Maybe 2 or 3 countries meet. It's quite interesting rather than just an in-country. But for a start, it's good to have an in-country conference and then move on to inter-country, conferences.
Yes.
Yeah, and the issue of collaboration, especially in research, is very important, because we have, the settings are more or less the same. We have similar problems. Yes. Having multi-country studies, the credibility, it's quite high. So,
I agree.
Yeah.
I think it's a wonderful idea. I think it's something that if we, led by you and supported by the chapters in the continent, I think other countries will buzz and hear about it. Hopefully, we can do this without being, I tell people, you want the support of your ministries and government, but if you don't, we can still plan a conference. I said, but once you do something like this and they watch, then they're going to support you. You know how Africans think. Once they see a magnitude, you heard Dr. Demby when he said it.
Yes.
I'm looking at it, I'm thinking only 200 people will show up. The hall is full. And I'm like, oh, Jesus, thank you. So I think now people, they have to believe that we can do it. And when we show that we're doing it amongst ourselves, then they'll be like, oh, this looks like a good idea. Okay, how can we support this effort? I tell them in Sierra Leone, you guys in these NGOs, people come to Africa to do so much research on us. Why you don't hold them accountable to sponsor you?
Very true. We are doing a lot of research for them.
Yes.
Yeah. And our role is just to coordinate their studies, to collect the data for them. They take the data, off they go. Some of them will involve you with analysis, some will do everything on their own. So that we have to break that and move forward, do our own research studies.
Yeah. It's just, we have to get out of this being used system. It's the enslavement mentality. We've got to leave that alone. Doc, let me tell you, the chief nursing officer, Mary Fuller, she's one of the first ones I inducted, right? She said out her mouth to me, after I did the ceremony for them in New England, in Christiana Masalé, the registrar's office, then they did an induction and they had the other 4. Then I did a next ceremony at the Radisson Hotel. Mary Fuller said out her mouth, her goal for us is to one day have a research conference. I always hold her. I said, you remember the day you said that out your mouth? I said, it's come to light now. I said, you have people now making it come to light. So if we know that we have a plan for not only our country, but for the healthcare sector and how nurses can be involved, because we're the bulk of the healthcare sector, the nurses, we're the bulk of them. How can we now highlight the country, and also these people come, it's no longer just come to use us as guinea pigs to test and walk away with the data. No, you have to leave some deposits. So now, if you want to do this with us, you have to pay for a venue, you have to pay for our catering, you have to sponsor us with this. Like you dealing with these members, I had a little bit, it was issues, because I'm just like, why don't you ask the people, all these entities, they gave me a slew of names. I said, why don't, their budget season and this. I said, well, then you learn now from this conference, you're going to have a full year to prepare, do it in advance. I said, but you hold them accountable. Your bodies and your minds are not for free. To be tested on is not for free. To just say, our internal issue is this, and then you walk away. No, we talk about what we're going to do about it. And let's talk about some of the greatness. Let me to give you an example. When I had a malaria issue with my son, and we came back to America, I took my children to Africa for 3 months. And my son ended up getting deadly malaria. Do you know what saved us in the hospital? The doctors brought out an article on the phenomenal research happening in Sierra Leone. We had 25 physicians. The doctor brought it out. Do you know they had to fly medication from another country? If I'm not mistaken, it may be Africa. They flew medication from another country and brought it to us. If not Africa, India. They said, we had to fly this out from out the country to come treat you all for malaria. Then the doctor looked at me, the attendant. He asked me all the symptoms. He said, Mrs. Dow, Mrs. Sisehara, I want you to understand that we've always talked about deadly malaria and malaria cases. You are the first one to walk in our institution, Morgan Children's Hospital, last year, July.
Yeah.
You're the first case. He said, because of you, they were perplexed. They wanted to know, because they learned how to treat, and they did an amazing job with my son. And from that, I learned how to better treat malaria in Sierra Leone, because they were giving albumin and blood and offered platelets
Yes,
and fluids.
so I think we can plan to have some talks as we go along.
Yes.
Beyond the conference, where we can discuss more on how best we can work together, how we can collaborate, and the issues of research to be conducted by nurses is very important.
Yes.
But the limiting factor has been the funding, but also for the nurses to understand the importance of disseminating what they have done so far, the work they are doing,
and be
very
proud
important. Yes, we have work done, but we don't have conferences for us to go. Each conference requires you to have funding, but when you have in-country conferences, when you are able to raise some funds, it helps a lot. And I think nurses will be motivated because of that.
And our funders may not be the traditional people who fund. There are people in the diaspora who want to be involved.
Yes, that's what we need. We need to link up with people in the diaspora. Some of them, they have some links with those funders. We can easily join up and write research studies and work together.
Yes.
I think. Yeah.
And I think after what I can ask you to do is just maybe do an email introduction of your chapter in Africa. Email of the chair member and president. Introduce all us, and then we begin the conversation with that. And then you create a timeline for us for your goal, and let's bring it to life. I think it's an excellent idea. But let you all get back to the conference.
Okay, thank you. Yeah, nice talking to you. Yeah, thank you.
Thank you.
Bye.
And everyone viewing us online, we just had some wonderful words from Dr. Agatha Bula. She is our Sigma Region Africa coordinator. She is tuning in live and speaking to you all from Malawi. So we are very excited about that. We're excited for all of our various nurses popping on and off on the Zoom, for you all watching us live broadcast here on social media. And we just want to wish, today is a day for Africa, just not Sierra Leone. Today is a great day for Africa. And we want to just congratulate for the success of this. We look forward to an Africa region conference, and let's do the work. Enjoy, guys. Sorry, the Zoom dropped by mistake, everyone. Hold on, let me call the gentleman. He didn't turn the mic on. Ibrahim, we can't hear the Zoom. So please turn the mic on. So as they're speaking, everyone, hi everyone, hi Rugi, welcome.
Hi, Zainab, how are you?
Great. So as they're speaking, everyone, I know we are live broadcasted on YouTube right now. We're live on Facebook. Again, we just want to welcome everyone to the 2022 first ever annual research conference. This is nurse-led, but it's for everyone. It's for doctors, nurses. It's for people in pharma, the whole medical community to come out. We were graced by the presence of the Minister of Health, Dr. Austin Demby. On this line right now, we're honored. We have some Sigma members, and we have Rugi Atuba, who is a Sigma member from Epsilon Mu chapter in New York. We also have Delta Zeta members. We have SLNA NYT members, various SLNA members who are tuning in and watching the broadcast, whether it's on YouTube, on Facebook, or here on Zoom with us. Rugi, I would like to introduce to you, we have Dr. Agatha K. Bula. She's on our Zoom right now, the SLNA Zoom, right now, tuning in from Malawi. So she is the Sigma African Region Chair. And this, Dr. Bula, Rugi is one of our powerhouses in Sigma, one of our powerhouses in SLNA. So we want to welcome you all. We're live broadcasting from Freetown City Council right now in the auditorium. Thank you to Mayor Yvonne Akisoya for making this happen for us also, and all the colleges and schools that they're announcing right now. So that's what everybody is doing. They're representing the different various universities and hospitals and clinics in the country.
Thank you, Zainab.
Anytime for Africa.
One, two, 1, 2, 3.
Dr. Lawrence Babao has a great publication profile in high impact factor journals, including 3 textbooks. Ladies and gentlemen, I hereby present to you our own very, very dynamic, focused, result-oriented. You can look at those at any time ready to support. I present with Dr. Lawrence Babao. Dr. Babao.
Good afternoon. Now, I also want to stand on a protocol to speak. Thank you, Anita, for that introduction. Well, my role after the stay is very short notice, but being a nurse and being somebody that is ready to perform tasks and duties that I usually offer, I take the responsibility to take the role that I will give. So I'm not a key presenter, for which I'm very happy. Thank you to the organizers of this conference for singling me out to present a paper, or rather a speech, on this very auspicious occasion. I stand before you today as someone who comes from both clinical and public health background, where I have spent some years both a clinician and as a public health professional. However, I have found out that the greatest threat to our well-being as citizens comes in the form of an enemy which cannot be seen by the naked eye, namely the virus that causes infectious disease. The theme of this conference, infectious diseases, health challenges across the lifespan, cannot be more appropriate at this critical time in the history of epidemic and pandemic outbreaks in the world, including Sierra Leone. Indeed, more people have died from diseases than from natural disasters or civil unrest. Tens of thousands of people have and continue to suffer from a myriad of infectious diseases, including dengue fever, tuberculosis, malaria, HIV/AIDS, hepatitis, Lassa fever, and in recent times, Ebola virus disease, and of course, COVID-19. Nothing is more worrying for us today than the specter of pandemic and scientists and medical researchers have for years differed over the exact definition of the pandemic. But one thing everyone agrees on is that the world describes the widespread occurrence of disease in excess of what might normally be expected in a geographical region. Cholera, bubonic plague, smallpox, and influenza are some of the most brutal killers in human history. And outbreaks of these diseases across international borders are properly defined as pandemic, especially for which throughout history are still between 300 to 500 million people in its 12,000 years existence. In the DR Congo, for example, there have been many outbreaks of measles, malaria, monkeypox, cholera, vaccine-derived polio, and rabies. Every year in the DR Congo, 300,000 children under the age of 5 die mainly from preventable causes. Sierra Leone too has had its share regarding infectious diseases in the recent past. From May 2014 to November 2015, Sierra Leone experienced the largest epidemic of Ebola to date, which affected its neighboring countries of Guinea and Liberia. The epidemic in Sierra Leone resulted in more than 40,000 cases and nearly 4,000 deaths. In this address, I will restrict myself to COVID-19 because the COVID-19 pandemic response. As humans have spread across the world, so have infectious diseases. Even in this modern era, outbreaks are nearly constant, though not every outbreak reaches pandemic level as COVID-19. Today's visualization outlines some of history's most deadly pandemics, from the Antonine plague to the current COVID-19 event. Diseases and illnesses have plagued humanity since the earliest days of our mortal flaw. However, it was not until the march to agrarian communities that the scale and spread of these diseases increased dramatically. Widespread trade created new opportunities for human and animal interaction that sped up such epidemics. Malaria, tuberculosis, leprosy, influenza, smallpox, and others first appeared during our year. The
The more civilized humans became, with larger cities, more exotic trade routes, and increased contact in different populations of people, animals, and ecosystems, the more likely pandemic would occur. Despite the persistence of disease and pandemics throughout history, there is one constant trend over time: a gradual reduction in the death rate. Healthcare improvement and understanding the factors that incubate pandemics have been powerful tools in mitigating their impact. Beginning in December 2019, in the region of Wuhan, China, a new novel coronavirus began appearing in human beings. It has been named COVID-19, a certain form of coronavirus of 2019. This new virus spreads incredibly quickly between people due to its newness. No one on earth has an immunity to COVID-19 because no one had COVID-19 until 2019. While it was initially seen to be an epidemic in China, the virus spread worldwide within months. The world saw more than 500,000 people infected and nearly 30,000 deaths. With the coronavirus pandemic, people all over the world have become more aware of the best practices during a pandemic, from careful hand washing to social distancing. Countries across the world declared mandatory stay-at-home measures, closing schools, businesses, and public places. Dozens of companies and many more independent researchers began working on tests, treatments, and vaccines. The push for the human race to survive the pandemic became the primary concern in the world. The outcome of COVID-19 is impossible to predict, but we can learn from pandemics in history to determine our best causes. These are our teachers. The Spanish flu, for example, the HIV pandemic, and more. COVID-19, as we all know, has flu cold-like symptoms, but causes severe pneumonia in some cases. In some cases, the disease is life-threatening and autoimmune response not yet fully understood, probably caused by cytokine storm. It is a strongly age-related disease. Infection risk and severity of disease vary widely by age, being especially severe in the over 50s and those with comorbidities. For example, the overweight, diabetes, etc. There appears to be a genetic factor in whether the disease becomes life-threatening. These are yet not well understood. There are strong variations in infection rates and impact according to location, class, occupation, and ethnicity. Some of these variables are not well understood. For example, whether poorer communities in sub-Saharan Africa are protected by an outdoor lifestyle. It is known that the peaks of infection predicted by models are rendered too extremely strong behavioral reactions. For example, people wearing masks, sheltering at home, undertaking self-isolation when symptomatic and adopting food and activity. There are some general rules for epidemic control. Notably, social distancing and masks reduce spread of infection significantly, and vaccination works well, but it's not a complete answer because vaccinated patients can be symptomless. But there is no single set of universal restrictions.
each country has to find its own way based on local considerations, be it demographic profile, climate, or practicality of measures adopted, such as market lockdown or movement restriction. Severe control does not work in the sense that the disease continues to spread and the economic damage can be high. The virus rapidly evolved due to high infection levels and pandemic spread. So far, there is a tendency apparent for the mutation to facilitate infection. The direction so far has been towards milder but more rapidly spreading variants. But there is no guarantee that more deadly mutation will not arise with selection advantage. Virus needs global containment to reduce such risks. Containment can be facilitated by more effective vaccines and treatment. But distribution issues of vaccines and new treatments require to be addressed. There are some general issues of infectious disease management, more general. Infectious diseases are not diseases of childhood. COVID-19 shows that it can also be major problems for the elderly or people with poor general health. In Africa, protecting the elderly is often a challenge because strong social isolation is a threat to welfare of the elderly more generally. There is also a problem of vaccine resistance, reflecting the perception that vaccination is for children and not adults. More attention needs to be paid to the need for protection from infectious diseases across the entire lifespan. What needs to be done to give teenagers protection against hepatitis, meningitis, and papillomavirus, and to prepare vulnerable adults for seasonal vaccination against flu and COVID-19. The general message is that public health in Africa now has to change, with more emphasis placed on the protection through vaccination and other means of citizens of all ages. Actually, it's no longer something for small children to know. In conclusion, we have an opportunity today to coordinate our efforts to reduce duplication and make the most of the scarce resources we have. Let me observe that investment made for Ebola preparedness and response are yielding benefits of COVID-19. There is need to continue to enhance capacity and promote research in a more coordinated manner. We need to invest more to sustain these gains while addressing the gap. I encourage all of us to continue to mobilize resources where possible to facilitate preparedness in our country. We should all advocate for increased investment in epidemic and pandemic preparedness from domestic resources in addition to supplementing necessary external support. I thank you all.
I think we deserve a more round of applause. Talking about health challenges across lifetime, concern about the spectrum of epidemics and pandemics that we have, and what better time to talk about if it's not leading the agenda. And I think going forward, we'll continue to lead the agenda through research, through our fourth international conference that we'll be having. And I think this is a milestone achievement for all North Christians. So all together, can we give ourselves a round of applause for this milestone? I think we'll come to the top of the agenda, the business of the day, the reason why we are here today, And we are calling the second session to order with a panel discussion. With me, we have our able Dr. Brother Michael Coleman, who will co-chair the session. It is not me speaking the show. Now we are at the table. We are not at the back. Decisions are not be taken on our behalf. We are leading the way. And when we talk about stigma is more or less looking at how you display your leadership qualities and also how we will be a role model. For this session, there will be 3 rounds of panel discussions, followed by questions and answers. Each panel discussion will last approximately for 1 hour, and we'll do our best to manage time. The moderator for each group will give an overview of the topic, and the team of panelists will talk around the subject matter. We'll have 6 minutes for the first round, planning the discussion, and another round where the moderator will pose questions and have a closing statement. After which the moderator will wrap up the session and then followed by questions and answers. I'm kindly appealing that we keep our questions something and to the point to allow all the community and make it lively and interactive. We have seasoned experts in the field of nursing who are special, and they are also members of a prestigious Sigma Delta Beta Nurse Interest Group. But on a lighter note, let me give you a joke around public speaking challenge for most of us, especially using a Queen's language. This is something in Sierra Leone and also around the nursing profession. I was having a conversation with the colleague on discussing how high-level personalities have struggled to pronounce certain words and have made some huge blunders. So, it's not their fault, it's not their mother tongue, so no hard feelings for that. A man in the top of that read the passage in the Bible. So people are impatient and wanted to progress. The said, don't see what's good, don't jump and start. So he thought they were trying to help people now to work. So he thought the situation. So I hope we'll not have any in this sequence here. So on that note, we want to call on Dr. Coleman to introduce the panelists for the first discussion, and also as we call upon, kindly take the high seat as we move along. Dr. Michael Coleman.
Notice, can do it? Yes. Colleagues, on this evening or this afternoon, to present to you the panelists who are going to make this session very educative for us. And we have 3 panelists in this first session. You will not believe that among us there are a lot of high-learned personalities that sometimes they are hidden, don't want to make themselves known. One of our panelists, who is no other person
but fellow Anita. She is a public health citizen working currently at the National Malaria Control Program and the Ministry of Health and Sanitation. All you want to know about malaria, this is the brain. I was going too fast. So may I go back to start with where we are to start? I think the first session will be focused on infectious diseases, and that is exactly from what our keynote speaker has just mentioned, COVID. We are going to hear share experience on viral and hemorrhagic infectious diseases. And one of our panelists that we are going to listen to is fellow Aminata Tigidanke Kuruma, who is a Sierra Leonean by nationality working for the government of Sierra Leone, the Ministry of Health and Sanitation. This wonderful lady is an intellectual and a graduate in the field of epidemiology training program, both in the intermediate and frontline level. She is a state-registered nurse and a certified midwife. At the same time, she has earned a master's degree in public health, a doctorate degree of public health student now, and a fellow of the West African Postgraduate College of Nursing and Midwifery. At the same time, she's a fellow of the Sierra Leone Postgraduate College of Nursing and Midwifery. This wonderful lady is a public health specialist, and she's a focal person for Influenza Sentinel Point. She has over 20 years of experience in working in the field of public health.
You know what? I literally just
the clinical setting, nationally and internationally.
Do I even
including
want to wear a
agencies.
because I don't need anyone
She
talking
has
about
participated actively in the major outbreak response in
every single
cholera,
time. Or remember what happened
Ebola outbreak in 2014,
on my face.
the multiplied in 2017. Currently, she's serving as the national surveillance officer and the lead for the National Sentinel Influenza Surveillance System. Fellows, I want to present to you fellow Aminata Kuruma. Tigidanke. The next panelist I will be joining here is fellow Kinder Josephine Selu. This fellow is a nurse from a family of medical personality, grandparents, sisters, and elder brothers. Josephine finds pleasure in nursing, caring for people, especially those physically ill. She is also
And somebody is currently working at the Lassa Fever Unit in Kenema. During the Civil War, when civilians were amputated, he consented to humanly serve the amputees at the amputee camp in Theta. Josephine later seated a service with affected women with fistula at the Navy Smith Hospital, Aberdeen. She has completed an assignment working with COVID-19 treatment center at Kobe College. Josephine started a nursing as a nursing aide and went through the rank and file, and today she holds a master's degree in public health. The third panelist who is supposed to come to the podium is a fellow Veronica Datu Koroma. Fellow Veronica holds a diploma in registered nursing, a diploma in midwifery, and a Bachelor of Science in nursing. And she's currently working in Kenema, in Lassa Fever Unit. And the coordinator for this session is our please, can we give a big round of applause to our president? Leone certification and speaker, Leone interest. This guy, come on. I want you to all the credentials. For the fact she already read a book like this, you can imagine the credentials she has. I don't know if you want me to read them. So let me just read them. But she's on top of everything. She's a fellow of the Postgraduate College of Nursing and Midwifery. She's a fellow of West African College, Postgraduate College of Nursing and Midwifery. She has a master's in public health. She has a Bachelor of Science in Nursing. She's a certified midwife, a registered nurse, and a lot of other certificates. So let us start for this all. And at the end of the hearing results, there will be time for questions and answers. Thank you very much.
Thank you very much. Once again, our noble occasion. We are honored as Northeast to start this event in infectious disease and viral fever. The findings for today have already been reviewed, and for the presentation outline, we'll do one overview of the response, the response for emergencies and preparedness. Then we move over to the case management, and that's what we've and community perspective. For a brief overview of emergency and infectious disease area, for years, all of us are aware that the health system battles with infectious disease
ranging from childhood illness of meningitis to adult infections of tuberculosis. Several diseases over the years have emerged, and prominent among them is the cholera outbreak in 2012 and Ebola in 2014. According to NDC 2012, infectious disease primarily affect people in low-income countries for reasons like susceptibility, vulnerability,
Hi, Zainab.
nutrition, and weakens the immune system, conditions,
Yeah, Rugi, we're live streaming. Yes.
Okay, so I'll send a message.
Send a regular text, please. Regular.
With the invention of penicillin and other antibiotics, but reported again with microbial resistance and emerging diseases like SARS and HIV/AIDS. Infectious disease has adverse effects and consequences not only on the individual, but as the nation as a whole. We have a brief statistics here of infections over the last 5 years. In 2019, we had an outbreak of Lassa fever, and we have 10 cases. The 10 cases we are confirmed by laboratories. We have 82 suspected cases and 2 deaths. In 2028, 2029, we have an outbreak of yellow fever. Wherein we have 9 cases, 2 were confirmed by laboratory tests, and 7 were suspected cases with 2 deaths. In 2011 again, yellow fever outbreak, which was 2, number of cases 2. We have 2 laboratory confirmed cases, no suspected cases and 2 deaths. The Ebola outbreak in 22 was the largest with 14,124 cases and 3,956 deaths, according to WHO. And we are still ravaging with the effects of COVID-19. Prevalence in Sierra Leone. Until 2014, Lassa fever was endemic in southeastern region of Sierra Leone, with sporadic outbreak of measles, meningitis, and polymyxin around the country. Several illness is still the leading cause of hospital visits in Sierra Leone, with 36% case fatality in hospitalized patients. According to SH scan, in the study prevalence of several illness among commercial and enzyme leak in the survey set, there was a significant IgM and IgG reactive to dengue virus, leptospira virus, and typhoid A, with widespread of bacterial malaria. This study was done in 2013. The Ebola outbreak was the deadliest and widely spread, affecting more healthcare workers than expected. The country had the highest burden of TB disease, and it's the 3rd leading country in Sierra Leone, with 57,000 people living with HIV/AIDS. Diagnostic facilities. Research until 2012. Research and other diagnostic facilities for VHS and other infectious disease was limited only to the Kenema Government Hospital. Kenema Government Hospital had facility for isolation and research. Until then, but now we have 3 facilities living on isolation and research within the country. And we can proudly say we have one at 34 Military Hospital, one at Connaught Hospital. Infectious disease and viral illnesses have similar symptoms and are often misunderstood. Interventions to effectively manage infectious disease is clear. The country has implemented a broad range of strategies to curtail on emergence of the disease. One among them is policy and training to improve detection and management of VHS, infection prevention and control practices within healthcare settings and communities, improve administrative control strategies such as triage,
infrastructure improvement, including isolation and intensive care wards, personal equipment. The country has reduced its list of variety disease conditions and events under categories like epidemic-prone disease and events that require immediate reporting, disease targeted for eradication and elimination, and other diseases of public health importance, and all suspected cases of public health importance to be reported immediately. Integrated disease surveillance reports to keep relevant data based on current evidence. One health strategy, a surveillance focus on point of entry into the country and the community, and an electronic-based approach to surveillance and disaster management. The country now implements a resilient health system involving political and economic and donor support to MOHS to ensure resilient health system in the country. Introduction to viral hemorrhagic fever. These are a group of diseases caused by several distinct families of virus. As the name implies, the condition affects the cardiovascular system, leading to bleeding and the body's inability to function well. The main symptoms are fever and hemorrhaging. Some of the cases are mild and sometimes asymptomatic, while others cause severe life-threatening disease in patients. The common characteristics of viral hemorrhagic fever is one, they are enveloped in a lipoprotein, which makes it easy to destroy them. They have the RNA that is similar to all of them, and they are easy to move from one person to the other. The signs and manifestations. Currently, Sierra Leone has reported a case of Ebola, Lassa fever, yellow fever, with suspected cases of Marburg in a research conducted in the north of the district, but this has not manifested in humans. It was just a fact. Manifestation. We have fever, fatigue, weakness, general feeling of being unwell, dizziness, muscle ache, joint pain, diarrhea, and bleeding. Management of spread. The disease is spread in two ways. The primary contact. This occurs when a person comes in contact with the virus in infected animal and infected habitat. Secondary contact when the infection is spread from person to person, either through direct or indirect contact in communities and healthcare facilities. The management of viral hemorrhagic fever is limited. There is no treatment for certain VHS, but vaccines are now available for some like Ebola. Symptomatic management of cases focusing on hydration and isolation and quarantine of infected persons. Destroying the host agent. Challenges. The spread of viral and hemorrhagic fever has led to globalization, international travel, and climate change. Leading to person transmission due to man-increased visits to the natural habitat of animals and insects. Poor laboratory facilities in low-income countries causing delay in isolation and identifying infection. Planning and irregular outbreaks, making it difficult to predict limited treatment and vaccine for their treatment. Colleagues, I introduced to you discussion on viral hemorrhagic fever in Sierra Leone, and with me, we start the fourth panel discussion with Anna Takuma presenting on Sierra Leone FCRN on viral hemorrhagic fever. Now I'm going to speak on the preparedness aspect of a topic, infectious viral hemorrhagic scenario. I'll talk on the preparedness taking surveillance.
Common causes of morbidity and mortality in Sierra Leone are mainly due to infectious diseases such as malaria, pneumonia, or acute respiratory tract infection, cholera, measles, and yellow fever. Prominent also are the epidemic infections. Those are ASP, yellow fever again, HIV, Lassa fever. Right up to surveillance. What is surveillance? Surveillance is the systematic collection of data for reporting and for action. Data, reporting, and action. So as you go along, you learn. Now to the development and establishment of the surveillance system, all programs collect their data individually. And I've talked to a large extent, it is uncoordinated. And the body cannot be seen. So the surveillance system was established, and in 1999, Sierra Leone Food of adopted the IDS system and then formed. This system in the beginning just looked at just 5 diseases, which are ASP, which is acute plastic paralysis, measles, yellow fever, neonatal tetanus, and diarrhea. But that was not enough. So in 2004, the IDSR was also edited to have a technical guideline. And in this technical guideline, 22 diseases, or diseases, we are selected. And it was still not enough. So in 2008, the IDSR technical guideline was further edited in line with the IHI, which is the National Health Organization. This is a decision instrument that is used to categorize disease models and how to respond on these diseases. So you can see in this COVID-19, that instrument was used to respond to COVID because we saw some of the questions that are asked in that instrument or that are asked in that instrument. Say, the disease of significant importance, can it spread through borders? Can it stop movement of people? And we saw all that before. You agree with me? That was it. So the IHR was included, and then the diseases were added to 37. Because there are challenges in the surveillance system was affected, and then activities were run through the action plan that was developed. These activities include training of national staff, the surveillance, and also health facility staff. Now we have consulting in the health facility. Notwithstanding all this, the surveillance was still inactive. Now training Ebola in 2014. It started in Guinea, then and Liberia. We all agree that we are called pants down. Why? Because we are not very prepared. We are not prepared and we didn't have the support. Then so many people died. Over 11,000 people died according to the data. And the cost for labor, professional activity was also projected to about $53,000. The negative documentation on Ebola's impact was attributed to insufficient healthcare system, that is the high-volume system, which is the surveillance, ICT. All of us that fought Ebola knew that ICT was not in place, and also access to specialized health personnel. Indeed, to improve on the surveillance system was enhanced to build its resilience for high volume.
and surveillance and IT all level, meaning this is the national and the community level. So things are conducted surveillance staff onto the health facility level. This definition, standard case definitions were developed. These definitions are set of criteria used to categorize disease. And they are made standard so that if we identify a disease in that are used in 3 towns and even out of the country, the traffic approach, this is the same criteria that we are going to look at in area, urban, rural, or wherever in the district. So these tools they are developed. Response teams were also developed and deployed. The ICT was also looked at for standard precautions. This communication was enhanced and also community engagement. We all agree with me that during Ebola, only when the communities were involved that we are able to contain the disease. So after this improvement, now saying 2021 Ebola epidemic. So what did we do? We wanted to assess our preparedness for any eventuality. So we set up to assess our preparedness and we selected 8 districts to go to their community to look at the preparedness and to see where we can support in the preparedness and also for active case search. So 8 districts were selected, more than districts, namely Koinabubu, Calabar, Kaine, Kambia, Kongo, Kailan, Kelema, and then Kidel. So we went into these 8 districts to administer the assessment questionnaire on 8 pillars. We looked at coordination, epidemiology and surveillance, laboratory, point of entry, case management, risk management, risk communication, community engagement, logistics, and
Give me a second. Let me see what happened with the cameraman. Hi, Susan. Welcome. Sorry, we're just the media person. You know, unfortunately, in Africa, they have to have enough data to go live on these phones and devices. So the guy is putting data on the phone right now. I just ask you all to bear with us. You know, we're going live and we're streaming on YouTube. So he's about to do it right now. Everyone just bear with us. Just give him 5 minutes. He's doing it right now, the data on the phone. Unfortunately, you know, being in Africa, this is what it's like. It's quite expensive to, you know, keep data and top up and everything on the phone. And these are just some of the challenges that, you know, do affect our healthcare system when it comes to light and technology, which is very imperative. But we just ask, we thank everyone for being on. We thank Susan for getting on. Susan is, I think she's tuning in live from the UK. We have Serena tuning in live from the UK. Thank you to Sumbo tuning in from New York. Mariama, she's either tuning in from New York or Pennsylvania. And we have Dr. Bula tuning in from Malawi, who is our Sigma region chair for Africa. And myself, and we're tuning in live from, again, I'll just let everybody know. It booted myself out. But we have everyone tuning in live. We have also Dr. Bula, which is our Sigma Africa region chair. And we're just waiting for our media man to get back on, but we're tuning in live from Freetown, Sierra Leone live today, Friday, March 25th. This is the first annual international conference, nursing conference led. It's hosted at Freetown City Council in the auditorium. Again, we want to thank the Honorable Mayor Yvonne Akisoya OBE for accommodating us. She's the one who gave us the green light last year to get this venue. We want to thank Dr. Austin Demby, who is our Minister of Health in the Republic of Sierra Leone. We thank him because he's been an avid supporter of SLNA for a very long time. And just give us a couple of 5 minutes. Our cameraman he's back on with us. He's going to stream us back in live in the venue and our audio. And we also ask you all to share SLNA. We're sharing this live on YouTube. Okay, enjoy everyone.
So my statistics here, let me briefly give you the statistics between let me give the statistics. Thank you very much. We are Josephine. We are out here. We come back. We are now asking the staff of people finally very to give us the patient.
Good afternoon, all. I'm honored stand before you to talk on Lassa fever, community, and patient perspective. Lassa fever is often a fatal hemorrhagic fever disease. Yes, it's in the same family of Ebola, wherein the blood factor is being tampered with by the virus, and therefore, when bleeding is uncontrollable, it leads to death. Although in some of patients, no bleeding occurs. It is a genetic, that is a disease that is found in animals, especially in Mastomys encephalitis, a multi-mammalian rat. If you see this rat, the female rat has 12 sets of breasts. Therefore, when it is in the community, it's not the quantity that is there, but at the range and the speed that it's multiplied and produces. An estimated 100,000 to 200,000 infections of Lassa fever occur annually, with approximately 5,000 deaths in West Africa, especially for Sierra Leone and Liberia. Lassa fever has been in Sierra Leone since the 1960s, but it was only discovered in the 1972 in Sierra Leone. Surveillance for Lassa, those standardized, but mostly we have good estimates. In some areas of Sierra Leone and Liberia, 10 to 15% of people admitted to hospitals annually have Lassa fever. The other main difference between the Lassa fever and the Ebola is that science has proved that Ebola can be asymptomatic. But I tell you, my dear audience, Lassa can be asymptomatic. In Sierra Leone, the most recent happened in 2019 at the Matanga Hospital, wherein a pregnant woman who was Lassa positive, but unknown to the health workers, was done surgery on, and which led to at least 5 deaths of health workers, including a foreign doctor. In Sierra Leone, Kenema is the endemic district, and especially the lower Bambara district. And therefore, the treatment center, all other hospitals, the cases, the suspected cases are being isolated. But for treatment, for now in Sierra Leone, it is only at the Kenema government hospital, where we have at least 25 health workers of all cadres, doctors, PHOs, and nurses of all cadres and support staff. The facility treats over 500 suspected cases. Community perspective. For every year, when there is denial, cooperation, compliance can be had. All we know in Sierra Leone, rats is part of our food delicacy, and especially in the provinces. Like for now, farming is going on. One poor, anytime these bushwalks come up, our idolism, one of their games is hunting rats and taking them home. And for our low class women or families, for any time these are hunted, it takes days without even going to the market to buy fish from you. This is a very quick thing. So it is difficult for them to appreciate it because they know they've met their grandparents doing it. For our patients, all they know, especially those who present with bleeding, is that it is native. African cosmology believes that diseases are not caused by human beings, either animals. but it is either a cause from God or from each other. So therefore, up to this moment, we need education. The treatment, according to WHO, the trial drug ribavirin is still being used at the Lassa Treatment Center in conjunction with supportive drug, IV3, hematinics, blood transfusion, antibiotics, analgesics, and antipyretics. We have time here. So can we please see to the next page? Let's proceed to the next page, please. Let's proceed to the next page. Now we have had an overview of infectious disease value. Go now to question 5. And one of the questions goes to the preparedness. One tomato explain the World Health Strategy and its benefits to value. So One Health. One Health is a strategy that was adopted in Sierra Leone to do cross-sectional collaboration or delivery of health to humans and animals and the environment, looking at the Ministry of Agriculture, the Ministry of Environment, and the Ministry of Health. And as you had seen that in a presentation during Ebola, they use other NGOs, that is to say, the military, the police, the fire force, and so on. So this is just bringing people together in different sectors to respond to. Thank you very much. I'm not talk about answer to One Health situation. So just saying, can we give us a backup on community management of consensus cases of Ebola incident? As I have said, though you may allow me to continue my presentation, I want to believe the community, a lot of was done to combat Ebola. Like I said, the establishment of community care centers in the community was one big move, because that was the time they thought. When the denial was there, people started escaping with their loved ones, as I said in my presentation. So as a result of that, during this, when these CCCs were formed, community care centers, patients are now encouraged, relatives of patients were encouraged to come with their patients in that community care center. And that was where they were kept for 21 days. Then after which, some of them that were brought into the hospital were also kept to the holding centers. Their samples, blood samples were collected, taken to the laboratory, and as they await lab results, some of them were cared for in that holding center. When their lab results were out, they were now moved to the treatment center. And as we said, Kenya Government Hospital was the only infectious disease unit at that time. So the establishment of the community care centers, holding centers, and then the treatment center really helped Kenyans to combat the virus. Last of fever management. We are talking about community perspective, and how do you manage that one, the health facility management of Lassa fever? Thank you, Mr. Moderator. At the last fever program, there are many units. We have the outreach, we have the units, the lab, and the administrative. In most cases, for the community perspective, education is ongoing. As soon as a positive case is taken to the ward, one or two nurses together with the outreach team go immediately to where that positive case is, and psychosocial therapy is being given to the relative and the community as a whole. Because sometimes it is stigmatization crops up. You can see the neighbors, even if they were going to that house to go and fetch water, fire, and the lights, like in our community, in our rural setting, all that will be stopped and they will just ignore that house. So therefore, the Lassa Fever program, which is a household name in Sierra Leone, sponsored by the Tulane University, has all those needs. Talking about surveillance system, what the ministry, especially involving nurses, have been the strides made to contain this viral hemorrhagic fever. Also looking at Ebola, the preparedness, community perception, as well as Lassa fever, looking at compliance, cooperative. And all of this, there has been issue about community involvement. I think that's a key lesson that we have learned. So now we are throwing it to you, at least you want to have not more than 3 questions that you might have for us, panelists as well as moderator, and they will respond to the question. Good afternoon, all. As my sister was talking about the hemorrhagic disease, we all know the myths and beliefs around hemorrhagic fever. How are you really dealing with behavioral change communication, and how are you monitoring people that they comply? Thank you. Good afternoon, all. My name is Tamara, newly graduated. There are a variety of diseases that have a unique circulation ensure that the use of syndromic detection and documentation and reporting as well. I know the Ministry of Health are trying very hard to bring private and faith-based on board, which is very good, but my question is, are they really complying? Because in the report that was read by our able president, she was lamenting on government hospitals only. And I can't tell the number of private and faith-based medical facilities we have, but I'm sure they are large numbers. And most of them are not complying to some of these measures. The reason why we need to improve and force them to comply, patients are avoiding government hospitals to private facilities, especially when they know they have infectious diseases. Okay? Yes, question, another question. One question. Okay, yes, are they really complying with private facilities? That's my question.
Okay, thank you very much for your presentation. I'm a little concerned about the One Health system in the Sierra Leone. Because I'm part of the supervisory team that normally go out to the district. And those are one of our thematic areas that we normally monitor. Most times, it's like it's not actually functioning the way it's supposed to function. So what are you doing as your unit to make sure that unit is revitalized, because it's actually very, very important, since most of the diseases are caused by animals, which is the most diseases. Thank you.
Thank you very much for the question. I think we'll hand over to the panelists. The first question was talking about.
I'm thinking, that's my problem now. Yeah, so I said maybe I could, because I don't want to go to the job starting. I wanted to go to pastor, just get a change of scene.
A moderator, and also talking about One Health system, the functionality of our One Health system, and also both Aminata will speak to that. And then the last one is talking about denial and proactive approach. If we are still, do we have more to do, or are we looking at Lisa? Over to you. You have just 1 minute to respond to this. And the first one, looking at facilities or nurses, restricting from the sites, and what led to that,
and whether there was program in place to put together preparedness for nurses to respond to the Ebola fight.
Okay, thank you very much, sir. You are very correct for your concern for the private health facility. As I speak, yeah, dealing with the private health facility. But before now, we've been trying to get them. But you know, as you know, we are not compliant. But last year in November, we sent letters to them that if they don't comply, their facilities will be closed down. And so they complied. We went, we assessed the facilities, those that are fit for reporting, and then we invited the proprietors for orientation of what is IDSI. And as I speak now, we are training them on IDSI. We've done the Western area, urban and rural, the Northwest district. It only remains the South and the East. By next month, to complete them, and all of them are now reporting electronically. Okay. In the area of One Health, I think we are in it together. You know our directory. We have the EPR, which is the Emergency Preparedness and Response meeting every Wednesday. And in that meeting, all stakeholders, MDs are invited. Maybe your unit, you are not attending the meeting. So even the agriculture and the environment, those are separate MDs, they are attending. And I want to say your director was even the incident manager for Ebola in this 2021 Ebola, meaning your directorate is part of the One Health. Let me just conclude on the myth and misconception. I told you in my presentation that we are involving the community. And because we are involving the stakeholders in the community and the community health workers who are in the community, they are helping out with the community misconception. Thank you.
Thank you so much, Madam Registrar from Liberia. I think what really happened during that time when our healthcare workers left the wards, they then CNMO, which is Osaka Tokano, together with her team, they went down to the nurses in the interior. They called all nurses, you know, it was a big meeting. And then she was there talking to nurses that this is our fight, we should not run away from this. And then what she also did, she also worked with partners. That was when they established the infection prevention and control. And all healthcare workers, as I said in my presentation, they were trained and then they were distributed in all the districts. So that's how the nurses came back. They were sensitized. And then the government also added some amount of salary, incentive, and they were motivated to do the job.
Good afternoon again. And to my darling younger sister, you know, and Sister Bawa Kangai, you posed a question on behavioral change. Yes, behavioral change. And this gathering, you know, we here have just come as a key to open a door to very big research plan in Sierra Leone. So therefore, my dear sister Kambai, even this behavioral change you've spoken about can be a whole research topic. Yeah, but yes, we can write on that, and especially when it is coming from us. So this is a very bright example that we nurses are thinking out of the box. So it's only for us to take our time, put ourselves together, and do something. But for now, for behavioral change, there is a research group known as the Breakthrough Action, together with the Job Upskilling in the UK
that are right now in Sierra Leone and have even done some research on behavioral change that can go a long way to help with the health workers to combat the infection of our community and ourselves. Thank you very much, audience and panelists. I think we have to round this off. We have battled with infectious disease and viral fever for decades. We cannot address it in 1 hour. We have made our points clear. Our presentations will be printed and in the booklet, the conference booklet, you get it. Whatever suggestions or addition we want to make, we'll have it written down and submitted to the group, so we'll add it to the presentation. But to manage time, we are in this conference with our international colleagues, so we cannot deliberate for long time because of time. We'll break for now. I want to thank the panelists very much for participating in this program, and now hand over to the chairperson to lead on the next program. Thank you very much. Thank you so very much. Viral hemorrhagic fever. My brothers and sisters, we'll talk about COVID. COVID actually, as we say again, with COVID, I think there are some good and bad side about COVID. COVID enables people, especially children, to know their fathers. Relationships do better because the men are able to stay with their wife. So there are some good things about some of these things, some of opportunities arise. The testing of COVID was also a very big issue. People in the initial stage, they were very excited when they were tested for COVID because they have to wait about 72 hours for the test to come. Let me give you just a joke to lighten things down. There was a conversation between a husband and a wife, and in relation to COVID. So the husband said, "Wife, you're negative. You know us women. We looking at a lot of perspective or angle. And the wife, because of all this anger, maybe some of the treatment that he has been having from the husband, to begin to spill out. You are so insensitive, you are so self-centered. I go sick, a whole kind of negativity." But the husband said, "My dear, I'm just trying to tell you about you, so you're negative. Come and see the atmosphere." The woman was so embarrassed. And I tried to convince. So as women, we have weapons. Let us use our weapon, especially our mouth, to the best of our ability. Thank you. We have had an interesting discussion, a very scientific one, and I really want to have a little bit of time. And on that note, I want to call on the team that is going to give us a very short skit. We want to make it very interactive. Yes, we're looking at scientific discussion, but also to make the most of our time here. So over to the team that we're going to give us a very, very short skit. Kindly let us make it as short as possible. Over to you.
Good afternoon and welcome to our story title, Why Did Theta Die? Ladies and gentlemen, I present to you the students of the School of Midwifery, Makeni. Hey, Theta, my friend, how are you? I'm doing great. Thank you. Oh, thank you, my friend. How is city life? City life is great. Thank you. All this time I've been busy with work schedule. I heard that you are sick. That is why I'm here to check on you. How is your health now? Sir. My sister, since I got pregnant, I'm oh, when last did you visit the clinic? See this city guy. Talking of clinic. See this village. The only clinic we have here is a native doctor. Too bad. Too bad for you, my friend. Don't you know, as a pregnant woman, you have to make the clinic your friend. Don't you know you have to make the clinic your friend? Don't worry. There is no need for you to worry about payment. We have free health care. And you have to make the clinic your friend because it is very important for you and your unborn baby. The clinic, going to the clinic is very expensive. The clinic we have in this whole system is about 15 miles away from the village. I go there, my husband don't have money. My sister. Okay. We'll talk about that later. Let me go and visit my uncle. Take this. I bought it for you because I know you like it. Okay, let me go and see my uncle. I'm dying. I'm having fever. Oh my God. And I'm bleeding. Oh my God. I'm dying. Nobody to help me. Help me out of the hospital. Oh my God. This is what I've been saying. That's a pregnant woman. You have to make the clinic your friend. Now look at your condition. Let's take you to the hospital. Oh my God. Oh my God. Don't worry. I know, don't worry. Don't worry, just lean on me. I will help you. Let's go. Please come and help me. My sister is dying. She's bleeding. Please, nurse, please. Please help my friend Kema. She is dying. Look at her condition. Please, nurse. Please, that is what you have been paid for. Oh.
Everyone, they're performing a skit by some of the students from the midwifery school. I believe this is the midwifery school from or in collaboration with the midwifery school from Freetown.
Thanks for clarifying.
Oh my God, please help my friend. My friend. Oh my God. Oh my God, please help my friend Kema. I don't want Kema to die. That's why I was saying that Kema should make the clinic a friend. Oh my God.
Very interesting.
And our people are dying there because of clinic, because we don't have any clinic there. So that is why we rush her this afternoon. And then this came about time. Please for maternity leave. My friend, I
My name is Emma. Oh, you mean that you don't carry the ambulance? Wow. All right. Everything is not correct. Can you please help us with the people? Let me refer to just take care.
Well, let's see how it goes. Now, the man said, this is a problem. I think to survive.
Yes, nurse, the people is here now. Nurse. Nurse. Nurse, the people is here. Can we take her now? Nurse. Calm down.
Don't touch me!
Don't touch me!
Well, thank you so much for listening. The man did not make it, but we are leaving you with questions. Think about it. As you have seen the skit, why did the man die?
When we hear a tiny call, when the white must come together as one. Oh, and it's time to let a hand to line the greatest gift of all. We can go on, and day by day, that's a one. To make a change. We are all a battle, cause great big family, and it's true, you know love is all we need. We are the one, we are the big one, we are the big one, we are the one, with a better change, so let's start walking. We are the one. We are the one. We are the big one. We are the one. We are the one to make a better change. So let's start living. There's a choice we make it. To step on the next side.
Quelle vidéo?
To step on the next side. It's to make a better change, just you and me. Oh, let them your hands. So they know that someone cares, and their lives will be stronger than free. To the Lord, so say mountain side, and so believe the healthy hand. We are the one. We are the one. We are the people. We are the one to make a better change. So let's start living. We are the one. We are the one. We are
want to make a better change, so let's start it. Choice we make it to save our women's side. It's to make a better change, just you and me. Choice we make it to save our women's life. It's to make a better change, just you and me. Choice we make it to save our women's life. It's to make a better change, just you and me. We are trying to reduce maternal mortality rate. We are trying to reduce infant mortality rate. We made up our mind to be a midwife for the rest of our life. We made up our mind to be a midwife for the rest of our life. I'll put my mind made up, and I won't turn back, 'cause I want to be a midwife someday. I got my mind made up, and I won't turn back, 'cause I want to be a midwife someday. I got my mind made up, and I won't turn back, 'cause I want to be a midwife someday. I've got my mind made up, and I won't turn back, 'cause I want to be a midwife someday. Wow.
This is very, very, very touching. Very, very inspirational. For me, I actually got goosebumps because this is what happens in our community. This is what happens in our facilities. Millions of problems. We're looking at universal health coverage. We're looking at access. We're looking at how we can reduce this unacceptable way women are losing a life. Pregnancy is a normal physiological event, and no woman to go to give that life and then lose the life. So what's a better note to have the second round of presentation? Thank you so very much, full of midwives, student midwives, McKinney. So we move to the second round of panel discussion, talking about maternal mortality, identifying the causes, and overcoming the challenge. This panel discussion will look into identifying the causes of maternal mortality and addressing the challenges. This is a key discussion, especially looking at what the strike of the ministry is making to ensure that we really change the narrative of our women, our pregnant women in this country. And we have her for this. For this, we have as moderator, Mrs. Frances Poller, Head of School, Midwifery McKinney. She's the Foundation Fellow of the Leone College of Nursing, Midwifery Nurse Specialist, Fellow of West African College of Nursing. She has an NPH, a BSc Honors Midwifery, Diploma in Nursing Education, Diploma and Certificate Tropical Medicine and Health. She's a registered nurse and a registered midwife, as well as a doctor. Kindly let us rise as we respect our most honored Mrs. Frances Poller to the stage. Dr. Frances Poller. Also, talk us through this most important discussion. We have as panelists Mrs. Margaret McCarthy Milimana. She's also
a Foundation Fellow of the Sierra Leone Postgraduate College of Specialty, the Fellow of the West African College of Nursing, NIPA, Master's International Public Health from the Liverpool School of Tropical Medicine, specializing in sexual and reproductive health. She also holds a BSc Honors in nursing as well as diploma community medicine and health. She's also a veteran midwife and a reproductive nurse, a registered nurse. She's currently the program manager for the Quality Improvement Program. Every welcome as one of our panelists for this important discussion. Also, as panelists for this session, we have a veteran midwife, Matron Ivy Mtp. She's also a Foundation Fellow, Sierra Leone Postgraduate College of Nursing, Fellow West African College of Nursing. She also holds a Master's in Public Health, BSc Nursing, Senior Nurse Anesthetic, State Certified Midwife, State Registered Nurse, and she is the Senior Matron, Princess Christiana Maternity Hospital. Welcome, Madam Irene Hisse. Also, as part of the panelists, we have Zainab Dudeba, BSc Honors Nursing, SRN, and also Masters in Public Health, currently the National Coordinator of Maternal Health Surveillance and Response. Thank you so very much. And most distinguished, we have my personality. Our most distinguished personality, we have the Acting Chief Nursing and Delivery Officer, Matron Mary Mamakofula. She's also a Foundation Fellow, Sierra Leone Postgraduate College of Nursing, Fellow West African College of Nursing. She also Master's in Public Health, and she's also a midwife and nurse. She's currently the Chief Nursing and Delivery Officer in the Directorate of Nursing and Midwifery Services. So thank you so very much, moderator and panelists. I'll hand over to our moderator to lead the session. Thank you. Thank you very much, Madam Chair. Ladies and gentlemen, distinguished guests, good afternoon. Our panel discussion will open with a PowerPoint presentation titled Maternal Mortality and Morbidity, Identifying the Causes and Overcoming the Challenges. The panelists have already been introduced. But let me hasten to say that this presentation is the outcome of a literature review. And so the presentation outline will take the following format: introduction, we will state the objectives, take you through the literature review, methodology results, and then we will have our conclusions and recommendations. Introduction. Maternal mortality is one of the most global health challenges and development discussions. Maternal mortality globally has been considered as a public health issue. It has been considered as a human rights issue. But most of all, maternal mortality has been considered as a quality issue. When there is a maternal mortality, it does reflect the status of women, their access to healthcare, and the ability of the health system to respond to their needs. Highlighted are key indicators, next slide, which are very, very, very relevant to maternal mortality. First, I would like to remind us all that we have a population of 3.4 million, and then 41% resides in urban areas, and then 59% resides in rural areas. So even though, okay, I'll just finish with the population. And we also have a literacy rate of 51%. Life expectancy is 52 years at back. And then the healthcare delivery system is delivered by the government of Sierra Leone and private or faith-based organizations. But let me hasten to say that government of Sierra Leone actually provides 70%, and then the private or faith-based organization provides about 10%. We have a fertility rate of 5.2 children per woman. Family planning service is about 75%. When I talk about the services, it's the readiness of the facilities with regards to the services that they provide. So it's 75%. And minimum is 66%. And that is seen in Western rural. And maximum is 84% for Kenya. And the care service readiness is 66%. And minimum is 57% for Western rural, and then 74% for Kenya. The average term of services, please take note about the readiness of these services to serve the population. Minimum 70% for maternity, and then maximum about 90% for adulthood. Worrisome is that these deaths occurs, 81% of these deaths occurs in health facilities. Go back. 81% of these deaths occur in health facilities, 14% in communities, and 8% here in transit. Please, if you can go back. Okay, well, we move on. So even though Sierra Leone has made impressive progress in reducing maternal mortality rates, yet we are far away from achieving the Sustainable Development Goal 3.1, which is reducing maternal mortality to less than 70 per 100,000 live births by the year 2030. At the moment, we have 717 per 100,000 live births. So we cannot talk about maternal mortality without highlighting the definition. According to WHO, maternal mortality is the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. According to WHO, maternal morbidity has been defined as any health condition attributed to and or aggravated by pregnancy and childbirth that has a negative impact on the woman's well-being. So the chart that we have just passed actually shows trends from the maternal disease surveillance and response data. It has shown that, yes, the maternal mortality is decreasing gradually. In 2020, we have about 507. That's the chart. Next slide, please. Remember that I have said this presentation is the outcome of a literature review. The aim was to identify the causes of maternal mortality and address the challenge through a literature review that will inform this panel discussion today. Our specific objectives were: one, to identify the causes of maternal mortality and to investigate how the challenges of maternal mortality can be overcome. The literature review, we actually divided the literature review into two sections. The first section looked at causes of maternal mortality. And in the first section, further factors related to 3 delays model we are identified. The second section looked at challenges of maternal mortality and models to overcome the challenges we are reviewed and identified. Ladies and gentlemen, evidence has shown that there is no single simple, straightforward intervention that will significantly decrease maternal mortality. And so the review examined multiple interventions at all levels to achieve better outcomes. The review finally identified the socio-ecological model as the model for the reduction of maternal mortality. Methods, we looked at so many search engines and focusing on the causes of maternal mortality, and went a little bit further to look at the contributing factors and then what challenges exist and how to overcome. We looked at various data sources, but major source that we looked at is the Sierra Leone maternal death surveillance and response report 2016 to 2019. We also looked at the Sierra Leone demographic and health survey 2013 to 2019. WHO, World Bank, UNICEF, and other relevant publications. The results. 3 key results emerged from the literature review. 1, causes of maternal mortality. The causes of maternal mortality were hemorrhage, and hemorrhage accounts for about 43%. And these may include antepartum hemorrhage, postpartum hemorrhage, ruptured uterus. Next, we had sepsis. We had abortion or ectopic. We had other obstetric cause complications, which includes anesthesia complication, obstructed labor, embolism, cardiopathy, and the rest of it. We also had, as part of the causes, hypertensive disorders, and that includes preeclampsia, eclampsia. And there we are indirect causes, such as anemia, sickle cell, HIV, and AIDS, and malaria. Of course, sepsis includes nuclear sepsis, to mention but few. Next, another result, as I said, we went on further to look at the contributing factors. And these can be actually described using the 3 delay models. Delay in seeking healthcare, and we realize that there is failure of recognition of problem as part of the delay. Financial is one key problem, lack of awareness on danger signs, and social, cultural, and long-term delay. Another delay is delay in accessing healthcare. Cost of transport is one we have seen how the students have shown us as a huge barrier. Delay in referral from lower level to higher facilities for, and lack of transportation itself is another. The third delay was the delay in receiving healthcare. Interestingly, we found out that delay in providing care accounts for 50% on this third delay. And the other 50% accounted for lack of equipment and supplies, lack of personnel or unskilled personnel, poor or non-adherence to protocols and guidelines, such as the EMA protocol and the IPC. Ladies and gentlemen, in conclusion, there is no simple, straightforward intervention that will significantly decrease maternal mortality alone. However, there is a consensus on the importance of a multi-level intervention. In applying the socio-ecological model to reduce maternal mortality and morbidity, various levels contribute to go into maternal health outcomes. The recommendations from this panel discussion today will inform continued engagement of the Ministry of Health and Sanitation and other stakeholders on the implementation of maternal health in relation to maternal mortality and morbidity. Next slide. Ladies and gentlemen, you are welcome to our panel discussion. Next slide. Next slide, please. Thank you very much. Let me welcome you to our panel. The panelists have been introduced, so I don't want to bore you with that introduction again. But considering the fact that the socio-economic model has proven to be a multifaceted intervention that reduces maternal mortality. We have various panelists representing the various levels of the socio-ecological model. First, we have Metro Mana, who is representing both the individual and the interpersonal level of the socio-economic ecological model. Can you say hello to? So I have with me the matron of the PCM hospital, from Irene, who is representing the institutional or facility level of the team. Okay. On my immediate left,
Give us a second, guys. I think that we're having an issue with the camera. Okay, let's see what happened with the cameraman's Zoom. For now, till he gets back on the camera, I can share another link where you all can watch. We can also try on the Delta Zeta Zoom. But in addition to that, I will share with you all their slide presentation that they're going to present, their poster presentation. So I know that they're just beginning. Let me just share this with you all, the slides and the poster presentation that they're going to present. And that woman who is speaking is actually, her name is Frances Forna. She's the head of the midwifery school in McKinney, Sierra Leone. And she's also one of the heads of midwifery in the country. So she works for the ministry. And so they're doing some excellent work in Sierra Leone as far as maternal health. Their presentation will be on maternal morbidity and mortality. This is just some of the stuff that you can see. And I know Dr. Bula, you wanted to see with some of the statistics that they have. So this is, I won't go into explain. I'll give you all a chance to read. And I know Dr. Bula did want to introduce, we have Rugi Atuba, who is one of our SLNA members here, started with us in New York, and she does a lot of work in Sierra Leone. She's on the Zoom with us now. She works in maternal health. She's a nurse practitioner currently in Georgia. And so she's on. In Rugi, we have Dr. Bula, who's the Sigma Africa region coordinator. She's live with us here on this Zoom for the SLNA Zoom and tuning in from Malawi. So while they're getting back on the Zoom, I know Rugi can also tell you a little bit about, if she'd like to share a little bit about what they've been doing as far as maternal health in the country.
Hello.
Yes, Rugi, go ahead. Introduce yourself.
Hello, everyone. Thank you so much, Zainab, and thank you all for tuning in. And this is amazing. Like we here, especially in the state, we take our kind of like our chapters very seriously, and now it looks like it's like spilling over to Sierra Leone, which is amazing. Yes. And we can do so much with it. Yeah, these like chapters of the Sigma, it's like really important, and it's the connectivity between like now continents. It's amazing. So I encourage, like, especially people in Sierra Leone, nurses, you have so much power. You can do so much with what you got by connecting with other professionals around the world. So in this case, like, I know they're continuing again, but I'll just like to tell you guys that in Sierra Leone right now, I'm part of an organization called Mansari Foundation, that we do maternal child health. Basically, right now we're in McKinney, trying to help like educate our providers on the ground, helping like in clinic visits. And our kind of like founder, Cyber Mansari, she's actually presently in Sierra Leone on the ground doing the work that we're supporting from here. And so we're in Pamalap right now. That's what's the name of the village, in Masombo. So, and the goal is to go into the other villages in McKinney, try to empower them, make them be able to take care of kind of like care for the mother and the baby while doing it in a safe environment with the education to be able to support them. So that's what we're doing right now there. And then we have members here that do go back and forth to help educate nurses in Sierra Leone. And we've been doing it, and Zainab is like a big kind of like, how would I say, encourages even more members, myself and Zainab. We do go down and we encourage all the nurses in the diaspora to do the same thing. And it looks like it's been working. So, and we have Betty also is in Sierra Leone, I believe, right now. Yes, so Betty, these are all members that we do connect with. We go to help our medical system in Sierra Leone, and we work as a team. So wherever you're coming from, you go there, we all work as a team because we're all there for the same purpose. So and I encourage, when you have power to do something like that, it's a great feeling. And I can speak for myself and Zainab. When we go to do stuff like this, we do it selflessly. We don't do it because we're looking for recognition or we're looking for somebody to say, oh, this is what this person is doing. We do it because this is something we love to do, and we want to empower our nurses in Sierra Leone and also help in improving the health of our health system there. So I know I'm not going to say much, but thank you so much, Zainab, for always doing such a great job. And I hope more members will like kind of like take the role of going and do. You don't have to do a lot, just a small bit of what you can will go a long way.
It's not, it's Rugi, I just want to thank you. I know that the cameraman, he's unmuting. We're going to go back, but I just wanted to give this opportunity because Rugi, myself, a lot of us are doing, you know, individual efforts and collaborative efforts. We work with other organizations, and even to get this, you know, it took, You know, we have members who got on from UK's Susan Banya. We have Betty Foley, who's from the UK, who's there directly. We have people who are doing mental health nursing students. Serena's on the line from UK. You know, we're honored to have Dr. Bula from Maui.
As midwives,
and this
to
is
look at this
really important that we need you all to
that
just make
come to our facility,
your little
that
effort
need
will go a
our
long way
care
in Africa. So enjoy the
and end
conference,
up dying. I am here this afternoon, very proud to discuss these issues. And all of us are going to discuss them, not me alone, because we are all part of this in this session. So, 2016 to 2021, fertility deaths reported by NBS was 7,227.
Just the end, I have the end there.
That is between the fertility and the community was 242. Sierra Leone has evidence that women are dying in our care. And the major cause of this is poor human resources. We do not have the right type of human resource in terms of skills, mix, and like PCM hospital, we have people who to seek healthcare. We need more obstetricians, midwives, nurse anesthetists, and lab technicians. When we look at the health system service delivery, we are constrained in terms of adequate numbers of health workers. We do not have up to 10 obstetricians. And it's affecting the health. However, short-term ground measures have been taken by training chateaus, and also there is ongoing training of midwives. But we need trained gynecologists and obstetricians and midwives who are skilled and competent to be able to provide the needed care from our clients, the pregnant. There is intermittent supply of medical commodities in terms of drugs and other consumables that are inadequate. Poor compliance of EMO guidelines among us that will help us in our practice so that we deliver quality to our clients. In a country like this, where one of the major commodities that we need, which is a contributing resource, a contributing factor to maternal mortality, blood, it's nowhere to be sold. And even when people know that they need blood, people don't want to donate because they don't want their status to be revealed.
Thank you very much, Victor, from the PCM Hospital. Indeed, you have highlighted a lot of challenges, including
The human resource, there is inadequate human resource, policy is an issue, inadequate drugs and supplies and equipment, lack of blood, and the rest of it at the institutional or facility level of care. I will now hand you over to the coordinator for MDSR to talk to us about the community level in the socio-ecological model. Over to you, Madam Klein.
Thank you so much, good afternoon, all. For community, I will start for your MDS. So one of the objectives of MDS is to use the cannabis. Not only to the person track the number of maternal babies, exactly where the students are coming from and where the steps are going in the country. For facility there, assistant there is 1%, and also for community, you can see we have 12% of this. There's the point at community level. For NDHR, we recorded 451 maternal deaths. You can see the small figure going up, so we don't see maternal death with the public just action for us in health maternal death in the country. Also, with the community, the highest cause of this hemolytic, we know hemolytic is going in the country. So what we expect community to do is that to take
So I just have to do a video shoot.
and also the outcome.
Zone.
So we use the role model, and we know from community that we have to do. So we don't have a job of so
Yes, I mean, I had pass. You're online.
In some communities, especially for low educated communities, they expect the husband, family member, or other parents to take the picture for good. And let's also read the education, what we have for there's a delay. And this delay is form of so many problems. There need to test. So what we want to do is pregnancy must go when and how to take and also for disease of the future don't go to state sometimes and pregnancy because this is one of the things we see in our NPS and well and
Fine.
they don't know the
More fine program.
don't know the you can imagine some of the traditional beliefs that if you have one foot, another belief. If you have a bleeding, they get it to stuff. So can you see how ability to reduce financial through the model? And also for apart from the use of baby, we have our other models from lower facility down to the third facility to the seventh facility. Sometimes were through maybe the community member will go on to the situation, see there is a complication, so the system of where we have the issue. And also to see home delivery. We are seeing home delivery really happening as far as the critical. We have so many home deliveries. We can say it's already so much. What about the health club? Some of them are important and also these 12 complications that lead to maternity. So we can see how some of the in the community that help us maternity. Another thing from the access. For example, I was in community it's a 5 hours, it's a 5 miles to walk. It's a 5 miles for pregnancy, it's a short. Because you have to walk the distance from one to another place. There's a serious issue. So you can see the pregnancy out of complication, you see that sense. How can we solve it at national level? It's another issue. It's another issue of the access to road, the access of legal life. Like for example, that have a back for pregnant women. So if they are 36, so let me say 4. Yeah, so 34 to 36, waiting for them to deliver the safe environment. So that's another way we can.
Thank you very much. Thank you. That was the MDSI coordinator presenting on community level of care. Now, Madam CNMO, you are the policy person. So what policies are there with regards to the individual level of care, the institutional level, and then the community level of care? What are the existing policies? Please, over to you, ma'am. Thank you very much, Madam Moderator. Several policies have been developed over the years. The health sector recovery plan, which is being reviewed. The basic package of essential health services also being reviewed. The reproductive maternal child and adolescent health policies, and the new direction of policy, there is new one now, the free quality education policy. All these policies they speak to different levels of our healthcare delivery service. And in addition to that, the government is also signatory to many global commitments to improve maternal and child health. And this includes the UN SDGs, the Sustainable Development Goals, the Global Strategy for Women, Children, Adolescent Health, the campaign on accelerated reduction of maternal mortality in Africa, call for action, and the family planning strategy. All these have been signed by the government of Sierra Leone to ensure that the mothers, the newborns, the children survive. The policy speaks to the various thematic areas, because reproductive and maternal health, child health, adolescent health, and the health system strengthening. Let's take the maternal and child health. In accordance with the WHO guidelines, they have developed a package of intervention for each life cycle under reproductive health. It started in the pre-conception period of the woman, when she's not pregnant but ready to be pregnant. There's increased access to preventable and promotive health services at all levels, from the community level right down to the tertiary level, for various interventions, for HIV and AIDS, syphilis, for malaria, you name it. All these are in place. Screening and early detection and treatment of reproductive health conditions like cancer, cervical cancer. These are all done at various levels. Then we talk about the gender-based violence intervention at our facility level. In the pregnancy stage, what happens? There is supportive evidence-based programs and intervention. The ANC is our focus antenatal care, the provision of treatment of minor ailments, promotion of interventions at respectful maternity care at all levels. During labor and delivery, there's increased access to skilled birth attendants that are now in place this overview. Increase access to high quality maternal, newborn, and child care intervention. Ensure access to comprehensive MOP services in all the districts, and trainings are done in all the districts for midwives as well as non-midwives, as long as you are a nurse, you are trained on emergency care. Conduct maternal and perinatal death surveillance, as we have just now, and respond to improve maternal and child care. In the postnatal care area of the mother and child, there's increased access to comprehensive postnatal care. Increased access to postnatal family planning services. Now there is no postnatal family planning at all levels. And there is increase in CMC because we are now vying for elimination of transmission of HIV/AIDS from mother to child. For the newborn, we review and implement the national package for essential newborn care in line with the WHO guidelines. We now have newborn care almost at all district hospitals. Now we have MCU for newborn babies. We have also support and availability and utilization of community-based maternal and child health intervention. We have the mother support group. Thank you very much, Madam CNMO. Ladies and gentlemen, you have had all the policies that are available. The question is, are these policies being operationalized? This has actually brought us to the end of the first round of questions. Shortly, we'll move over to the second and final round of questions. And after that, the floor will be yours for questions and answers. Thank you very much, panelists. I'll start with you again, Ms. Romana, who is representing the individual and or the interpersonal level of the socio-ecological model. The challenges that you have highlighted are so many. And indeed, I agree with you that they have a strong link to maternal mortality and morbidity. What recommendations can you make here today to overcome these challenges? Many efforts have been made, but what can we do differently? Because this is no business as Zimba. Over to you, Madam Mana.
Thank you very much, and thanks, Rhoda, for this. I don't want to start with the obvious that we already know. People will say increase budget allocation to return ahead, appropriate policies. Because currently we have the most recent policies to be return ahead policy, where help to be non-catastrophic, meaning it has been evident from survey that 80% of our health costs is out of pocket. Many people are sick. However, survey we have a free health, but they are still under the table payments. Where most of us in here are guilty. So please, that's where I want to start. Our women are suffering. Even you that's educated, very difficult for you to make a living. And they are dying because of one way or the other our activity. So what I would recommend, looking at quality of care and also looking at international conventions and platforms. The key one is the Maputo. As really stated, African members, we should have at least some allocation, at least 15% of our country's GDP to help people. But they are still having. But we really want to thank the government. At least they have increased up to 11.something%. So that is very much welcoming you from NCR. Additionally, we need to have appropriate policies in terms of education, in terms of the social safety nets. and also in terms of family planning. Because you only die as a result of maternity when you become pregnant. If you are not pregnant, you can't die of maternity. So family planning is still hard to reach for women, especially the 75%, those living in the rural communities. And the draft midwifery mapping is clearly stated that most of our midwives are in the urban cities, living in rural areas where most of our women live without, for obvious reasons of which we are pushing and advocating for you guys to live. It doesn't matter. Globally, if you say leave no one behind, these are some of the things in sustainable development goals. Leave no one behind. It doesn't matter where you stay. Healthcare is accessible and secure for you. But in Australia, what we have done, we are sending the lesser cadres at the front line, and the clinical governance starts from point of care, wherever you are, whether you are in a village or wherever. The first person is here, your healthcare is needed, because the knowledge you operate with the knowledge you know. So Australia, we need to be advocating for at least the skilled people to be at the point of care. If I go anywhere, Ebola or COVID has shown, it will take you 72 hours before they move you, or Ebola can take you out of Australia. So we need to push for competent and motivated, trained people to be at that level where the individual can access safety. Then we also have to domesticate some international policies or laws that this country have ratified. One is the client or patient charter. Healthcare provision in this country, there is not accountability questioning. We are not accountable to our clients. We do not give them adequate information, and that comes to respectful maternity care. Similarly, we need to initiate and roll out respectful maternity care, so people are treated with respect, with dignity, and with compassion. Don't treat people because just. Additionally, we have to ensure that experience of care is being mainstream and make sure quality of care and quality of care is within our health worker training curriculum, starting from clinicians, that's for the medical doctors, at all levels, including our midwives. Then what I want to say, now we have the education policy in this country that was developed in 2014, and now it has been upgraded. We have to ensure that our girl child and our women folks go back to school. It doesn't matter, you need to have a formal education, but somebody has to be educated in somewhere so that they are employable. And at least if you have the means, see how our men folk treat women. Our men who are telling but we are not moving the cause of the women. Where are the boys? Where are we going to give the boys? Why we need to give the boys to the women? We need to give boys. Thank you so much. A very interesting discussion. It's a very, touching. We cannot say everything here. What we would like to do is to put all this discussion together and come up with a summary, and then we will see how we can disseminate to stakeholders. Thank you so much. Program manager, yeah. I will now hand you over to Madam Irene to give us a recommendation relating to institutional or facility level. We all need to come together in order to work on the lives, pregnancy, something. So, I'm particularly quality assurance by institutional We do external audit, external debt audit. We also need to look at our records. What times we charge don't document properly, and even the record business. So we need to keep all these qualities in place so that we do quality of service delivery for our clients. Capacity building for healthcare workers is also very important. As we have highlighted, inadequate obstetricians, midwives, nurse anesthetists, and lab technicians. We need all these ones so that we can increase the numbers. We'll be able to deliver. We'll be able to reduce the turnover mortality in our county. Also, supplies. We don't have adequate supplies. So, government, we look up to you to give us adequate medical supplies, commodities that we needed, and the reagents to the laboratory, which we lack most. And finally,
and I apologize. We're tuning in live from Freetown, Sierra Leone, so you guys know that there are challenges. I'll be communicating with the media man again, but everybody on this Zoom knows that we are, we all know the tech and infrastructure challenges with light, especially in this climate now, and also with internet. So just give me a few minutes. Okay, so what I will say is I'm going to put something on the screen for you all right now in Sierra Leone. They are shortly going to wrap up the first segment of this program. They are going to be giving out certificates right now. So the media man said they're just trying to allow them to charge their devices a little bit. But what I will say is so far we have on the phone, thank you, Rugi, for speaking. We have a nurse student, Serena Cowrie, who's tuning in from the United Kingdom. And we also have Sambo, who's a nurse here in New York. We have Fatmata Bengora Moses, who's a nurse here in New York, in addition with Dr. Bula. Dr. Agatha Bula is the Sigma African region coordinator, and she's with Sigma Theta Tau, which is an organization that we had started in the United States in 1922. I guess let me be respectful and take off the camera so you all can see me. It was started in 1922 for the viewers out there, because I know we're live streaming. And right now, Sigma is impacting all over the world. And right now we have the honor of having this very, very important research conference happen right now in the Republic of Sierra Leone, which is one country out of 54 countries in the continent of Africa. And we are, fortunate enough to have our actual coordinator for our continent on this very important groundbreaking day for the Republic of Sierra Leone and for Africa to have this type of research conference of this nature. The goal was we really wanted to engage the whole medical and healthcare community, because we have a lot of things going on in Sierra Leone, aside from, malaria, and not only Sierra Leone, all over Africa, malaria, maternal health challenges, nutritional challenges, mental health, which is another big one. So we're really looking forward to present on research and data on that on our next conference. You know, issues with HIV, tuberculosis, and just a plethora of things, sickle cell. And so we just want to be able to encourage all Africans around the world to please, especially if you're in the diaspora, re-engage yourself with these African nations, your home countries. Find a way, even on a small scale, which like Rugi said, find a way on a small scale to be able to, work with your community there. And there's a number of ways you can work with your community in your country. And we know that, if mental health nursing is your thing, find out, go to your country and figure out how many services does your country have to provide mental health services to the women and the men in your country, youth services. We have a lot of issues with sexual health and sexual assaults and awareness in our countries. And how do we work with them on that? You really don't have to be at the gold standard expert. You just have to have passion and drive. And if you have the clinical background and the love to help people, you can do that. And so we want to encourage all of you all, whether you work in pediatrics or med surg, or you work in geriatrics or community health, or you work with infectious diseases or sexual diseases, it's geriatrics, older adult healthcare, a community educator. We just want you to find a way to find yourself to be able to just mix it. You can start off working with the basic clinic. You could start off working with a school. You could start off working with the clinic in your village if there's a clinic there. Start off working with the local chiefs and the people who lead in your villages. Extend yourself out to elected officials, because sometimes they want to know how to get access to you all around the world and they don't know how to. And I always try to tell people, we can't leave this burden on the shoulders of just your president or just your ministry. I think for us, what we have to understand in Africa, it takes everybody. It takes a village. So for people like, for instance, Dr. Bula is on this call. If you have people who want to connect country to country, let's see how we can do that. There's a lot to learn. There's a lot for us to learn from each other. And so I don't think we just became nurses or people, whether you're a doctor, nurse, a pharmacist, a physician assistant, a nurse practitioner, just to work and make money, or just, be able to feed your just one household. There are things you can do that maybe not even cost you anything. You just let people know what you're doing in your community, like myself. People are willing to donate. People are willing to send supplies. People are willing to sponsor. And so we're hoping that this research conference empowers these men and women in the country to not only do more, but just be more. And also at the same time, let's recognize them and praise them. I think a lot of our healthcare providers don't get enough recognition, especially in Africa or from Africa, working out of Africa. So this is a day that we're really, really proud of. In addition to this conference, this week was the anniversary of the Sierra Leone Nurses Association, our mother chapter in Freetown, Sierra Leone. They're 61 years old. The anniversary was on March 23rd, 1961. So we really celebrate them for being around this long. We know that coming up next month, we also have the independence of Sierra Leone, which is on April 27th, 2022. Leading to that, we will have Nurses Week. And Nurses Week is a week that they celebrate around the world annually from May 6th to the 12th. And so we know we're excited to see what Sierra Leone will be doing that week. We're hearing that they may start their activities as early as May 4th, maybe to the 9th, or maybe even to the 12th. But we look forward, we invite everyone to come and participate with whatever we're doing in Sierra Leone. And I will share with you just some of their officers, so you can meet some of them. And so we're looking forward. These are some of the officers that you will, hold on. Oh. These are some of the officers for our current officers in Sierra Leone. So, you know, Sierra Leone is a country, they don't have a nurses union, and they don't have any other nurse organization. The only organization that we have in Sierra Leone for nursing is the Sierra Leone Nurses Association that supports the profession. We have midwifery, you know, but this is our only professional organization that we have. And the current president we have is Elizabeth K. Lamore, who is also the Sigma Theta Tau Delta Zeta, the Sierra Leone Interest Group current president. We have their vice president, which is Mr. Abdul Sase, Oris Naidamo, who is a secretary general, who is actually, he's a Sigma member, also one of the new members of the interest group. We have Mr. Daniel Sase, who's their assistant secretary general. We have Ms. Famata Lansana, their treasurer, who is also a Sigma member that we've inducted. We have Doris Sandy, which is their financial secretary or their treasurer. We have Mr. Musa Sori Conte, who's their public relations, their PR officer. And we have the wonderful Finda Josephine Selu, who is their social secretary, their organizing secretary. And about Finda Selu is the one who is the actual vice president of the Sierra Leone Interest Group in Sierra Leone. And so she's their program chair. So we want to really commend Finda Selu this is her first program ever as a Sigma member to execute, and she's been working closely with me to make this happen. In addition to, you know, the administration that we have for Sigma in Sierra Leone, and myself and Wanda Johnson and Dr. Claudette Gordon, who we have Dr. Claudette Gordon was on this call with us, on this Zoom with us, and Dr. Eleanor Campbell. The research chair for this conference is Dr. Ishiata Conte, who is in Sierra Leone herself. And these are just some of the people that we've been working with in the country. Let me see what else I can share with you all while they're in a little bit of a break over there in Sierra Leone. So the presentation that you guys saw was a wonderful presentation on maternal health. The last one they're gonna have is the presentation on malaria and pregnancy. And you can see that I showed you, I will share with you all some slides on, hold on. Slides on the, hold on, give me 1 second, I'm sorry. Slides on, okay, and so this, I will share with you also for some of you all who don't know what's been going on in Sierra Leone as far as this merge between the nurses group, SLNA, and Sigma Theta Tau. We successfully inducted, starting in 2019, but our first group in 2020 officially. Our three nurses have now, we've gone as far as 117 nurses in the country, with 2 that live in the diaspora, myself and Christiana Vandy. I'm between Sierra Leone and the United States. I spend half my time in each country. And these are our first group of, we'll show you, inductees. So the first 3 here in the front are the first 3 that inducted, which is Betty Lamar, the president here. This is the chief nursing officer of the country, Mary Makafula, and this is Christiana Masley, who is the registrar, who is responsible for making sure schools are accredited throughout the country and institutions and hospitals. And then we have Finda Selu and Josephine Saidu and Fama Talasana, and our first male inductee, what is Mahmoud T. Kagbo, who's doing his graduate work overseas now. After that, we had some intermediate ceremonies to present pre-certificates. And then this is our next large induction, which we had 56 nurses inducted in Makeni, Northern Sierra Leone. It was a wonderful event at Hotel Continue, and that was a really great day. And from then we knew that this day would come. And then this is our last, let me share with you all our last ceremony that we have done. And our last ceremony was done in Freetown, Sierra Leone. It was done, you see myself in the corner, of course, and we did it. And this is when we inducted our 117th nurse. We did it on January 9th, 2022 in Freetown, Sierra Leone. It was a wonderful event. And just to give you a little background on these inductees, these are the highest ranking people in the country. They are from all over. Our country is an estimated population of 7.4 million people. We have districts all over, and we have matrons who come from all of these districts. So some of these people who are attending this research conference today, they're coming from as far as 3, 4, and 5 hours away just to come and partake in this historic event. And so I really want to thank everyone for joining on the line. I don't know if anybody wants to share anything while we're on a break. If you want to share any words, if Fatmata, maybe you would like to introduce yourself. Sumbo or Serena, you're glad to do it. You can unmute yourself and introduce yourself if you like. Okay, and I'm just going to read some questions, which are great, that Dr. Bula has put in the chat, because we see that Sierra Leone has one of the highest maternal mortality rates, and we see a good number of women are delivered by traditional birth associates. I'm assuming that's what the TBA is. So we need to make sure the world understands what strategies do we use to ensure that our TBAs are providing quality care to women, and is there any specific training provided to them? And so, it's really great if we had one of our specialists, and that is the young lady who was on, who is Rugiatuba, who was speaking earlier, who is a SECMA member, who is an SLNA member. She was our corresponding secretary. So she is doing a lot of maternal care work in the country. She also works with the Mount Saray Foundation, and she also has another foundation, the Ba Foundation, that she, no, not the Ba, the Jallo Foundation, that she works with. And so every day we're working to figure out better solutions to provide for the women in Sierra Leone who are giving birth. And, which the one unfortunate thing is, we do have a quite large amount of young mothers there who are in their teens, who are, becoming new moms. And so we have a lot of challenges and a lot of strategies. I could share with you also, give me 1 second till we get off this break. I want to share with you, hold on. So organization that we have in Sierra Leone, one of our great organizations. I will share with you a picture of them. Give me a second. And let me see here. Let me get to their picture further down. So it's an organization called the Aberdeen Women's Center. I just was going to share it in the chat. Let me share with you all in Zoom, since we're discussing maternal health. Hold on, let me see if I passed it. Is there anything that anyone wants to share while I'm searching for the?
Hi.
Hi.
Yeah,
What would you like
so
to share?
I think you have indirected a lot of messages into the Sierra Leone Sigma. So I just wanted to learn from you how you are ensuring that they are able to maintain their annual renewals, because I think that's one of the challenges which we are facing in most of the chapters, whereby we are able to induct, but to retain them, it's an issue.
Yeah. Oh, yeah. Let me share this here. Let me share this here. So you're finding that you also in your country in Malawi, you're having those challenges also?
Yes, that's one of the biggest challenges.
You know, I really feel like there is what you mentioned earlier, I believe we have a continent conversation that we need to have, because I think sometimes what I feel is that, we're treating our countries like it's an isolated situation when it really isn't. The challenges that are happening in Africa are happening all over Africa. And I really feel like, we have this habit of, we feel that we have to figure things out on our own. And I really don't know why we've been used to this idea and this thinking for so long, and we realize it's not really working for us. We still face the same challenges. We're still going over the same hurdles. We're still working with the same entities, but we're still at the same place. And so how can we get growth in certain aspects, in certain sectors, or growth with, recover from, these if I want to say the word oddities, how can we really grow from these challenges if we're doing it alone? Even when we do it just in our own country, it's still alone, it's still alone. And I feel like I really appreciate and admire the fact that you're bringing this conversation to the table. You're not even targeting all of the healthcare community. Let's just start with nurses. How can we have this one word conversation about healthcare in Africa? How are we need to really engage nurses from other countries with nurses from other countries to see what they're doing, and to also share the research that they're doing. I think another thing is the mentality. I think we need to train our people to understand that when you go into work in the workplace, everything you do is data. Everything that you do is reportable. Everything you do is information to share with someone else for learning experience. And so I really feel like if we do a better job on our record keeping, record taking, but there's also things that we need to incorporate. We have to be honest. A lot of things that we're doing in a lot of our countries, they're outdated. When I go into some of these facilities in Sierra Leone, they're still writing things on pen and paper and record keeping that way. And so how can we have access to accurate information? How can we know that whatever intervention we implemented actually worked if we're not doing the real, taking the proper steps to record the data? And recording the data means somebody has to type it. Recorded data means somebody has to put it in a computer. And recorded data means somebody has to share it with email and put it into a database. That means a computer. So, you know, a lot of these things is, you know, the issue with infrastructure. And then that goes to funding. And so that conversation that you brought up earlier about how can we network with each other to find out who has the resources to assist us, on top of if we're using the same entities over and over, maybe there are other entities who want to be a stakeholder or want to be a type of a resource to assist us to help make these changes. And so, you know, I can't speak on actual numbers because my forte is not maternal health, even though I've worked in it. But, you know, I feel like the conversation of how we need to be problem solvers. And we really need to start learning to solve our problems ourselves. We have to figure it out. Africa has to learn to figure it out. And we have to learn to figure it out. We have to like find within who we know within our network who can assist us, and then be able to share that information with your neighbor to see, because if we start working that way, you know, regions will get better. And then when a certain region is doing a great job, and then the other region is going to that other region to see how they're doing, then we start covering this whole continent better. And people look at us that, you know, then they look at us as, you know, we become more self-sufficient. Because Africa, you know, it's you know, it has a lot of challenges. It has tremendous beauty, but it has a lot of challenges also. And so I think that's a real conversation that we really need to have. I will, once after this, you know, I can ask Sister Frances Fona for whatever data she has that I can share. But whatever she sent me via email, I think you've seen some of the records that she shared with us in her posters. A lot of these questions also are, you know, it'd be great if you had a question with people like Frances and the ministry to see what they've been doing, because, you know, Frances she's representing a lot in a whole country. And, you know, these are conversations that we need to be having, you know, sit down and have tea with this chief nursing officer to see what strategies and they're using, and what plans and things have been put in place to make changes region to region within your country. And then once you're able to get, you know, your country's able to hit certain benchmarks and success, you know, that's a tool and a model that can be used for your neighboring country. And so I don't know if there's anybody else who wants to share anything or have any questions that we can ask. I appreciate your engagement. We have Serena. You have we have a student who's online with us now from the United Kingdom, who's she's reading our chat and she's appreciating it, because there's a lot to learn from something like what we're doing today. And I don't know if there's anything else you want to share, Dr. Bula, before we go back to this conference. If there's anything that you want to share with us, or what your hope for Africa is. And if Dr. Bula doesn't.
Yeah, I think what I can say is I'm really learning something from the Sierra Leone group, because it has been a challenge to conduct a lot of nurses at once, but you guys have managed to do so. So it's something we need to learn from you. And as I already said, you know, organizing these conferences is not easy, but you managed to do so. Yeah, so it's something I know we can manage. What we need is to knock on people's door and see whether they can sponsor us to do something. Because the problem we have is we don't knock.
Yeah. Yeah, that's the thing. That's the real thing, Dr. Bula.
Yeah,
You
so
said
I'm
it.
hoping, I'm hoping most of the Africans will learn and see how best we can work together and also continue with the BCC scheme, because that's where the problem we have. Less people, we can't go forward.
And you said it. We don't knock. We don't knock. Like, asking for help is not always a bad thing. And offering help is always not a bad thing either.
Yeah,
This is a mental shift that we need to have, a mindset change, and I'm sure other countries and and other continents, let me say, go through these challenges. But today is about Africa, and I want to be bluntly frank. Today is about Africa, and today is about learning from Africa. And we're going to hear the stories and the experiences from people who work in and with Africa, who are African. But what we need to teach our professionals is it doesn't hurt to knock on a door. What harm is it going to do you to ask for the help? What harm is, and knocking on that door is she's being gentle about it, asking for whether it's financial backing, whether it's asking for supplies, but not just asking for things. Have a plan. Have a plan for what you see can be successful in this country and a vision for change. But I don't, sometimes, we have to remember that, a lot of our continent is in poverty. And that mindset it puts a stronghold on them that you can't get past that mindset, even as a professional. You have, professionals who are in the workplace, and because of that mindset, instead of becoming a giver, they become a taker, and or it just eats at their confidence. I'm there with them on the ground in Sierra Leone. Haven't been there today, but I was there, and I'm there, and I stay there most of the time. And there's a mindset shift that has to happen to show them that they have value, they're worthy for things, they're worthy to do things. I mean, look at the presentations that we're seeing today. These are people who have been in their career 20 years, some of them 30 years. Very, grown and mature people and established with huge titles who are afraid to knock. Period. Or feel that they have value among themselves, but not pass the country. Imagine that. They don't think that they have value past the country. And so things that they're learning from this, especially what Sigma is giving them this platform, is like your information is so resourceful to the rest of the world. The rest of the world, I have learned that firsthand, that the world learns from Africa. They don't even know how to deal with most of the things. And remember, our people are everywhere. So whatever happens in Africa affects everywhere. Look, during the Ebola crisis that we had the Ebola crisis, but they were shutting down communities here in the United States. We had task force teams created immediately, town halls, news, and everything. But it's happening in Africa but it affects the rest of the world because we're everywhere. So, I'm sure that there's a lot of learning lessons that people are going to learn.
Hey, Zainab, I'm sorry, it's Fatmata. I have to go, but please give me an update of what you guys are talking about later, okay?
Okay, no problem.
All right, take care.
Thank you for joining us. And so there's a lot of lessons, to be learned today. And I think the biggest one you mentioned is the door knocking. I think once we establish that, I think a lot of our hurdles will be over. It's not just waiting for people to come to you saying you need this or woe is. No, have a plan in place. Like, this is the vision for my institution. This is the vision for my center. This is what we want to see happen. Yesterday, we just, Dr. Gordon is not on. We had a huge major meeting with one of the nursing universities in the country. And they were elated that we came to them. They were shocked we wanted to even come to them. And I, looked at them like, why wouldn't we want to come to you? Why wouldn't deserve me? So they, they're eager and hungry for partnerships. They really are. And so I think we need to do better as we are South Africans who leave our countries and go around the world and come back. We have a full responsibility to Africa. If you think you don't, then don't call yourself African after today. We have a full responsibility to Africa to help it. We have a responsibility to give, and they have a responsibility also to take. Africa has served the world immensely. And so when they need help, give it to them. And when you can learn from them, sit down, zip your mouth and learn from Africa today. And so let's see, I don't want to over talk you guys in the group. And I know we have viewers streaming. Let me see if our cameraman is ready to join us back. Okay, you all just be patient with me. Let me continue to try to contact because they mentioned that they were charging their devices. Unfortunately, because of the crisis that's going on, Sierra Leone is having a major, major issue with light and fuel. So just be patient, please, if you can hold on. Okay, let me just see, because I'm calling, I think they were all, they were in their break, because they're having, time is it 11? Soon they finished their lunch, and they're trying to get back to that. They have about another hour of the event. So let me just work on some things to get you all back. I'm sorry, guys. You know, so this is the challenges we have. So, trying to get back on the Zoom because I know around Sierra Leone right now it is 4:20. Eastern Standard Time is 12:20 p.m. Sierra Leone right now it is 4:20 p.m. They are going to be wrapping it up, doing Q&A and their reception. But I'll share with you all some of the festivities and share with you all some of the pictures throughout the day. And so you all can see, again, we welcome everyone back to the 2022 first annual ever International Research Conference that they hosted in Sierra Leone in the beautiful Republic of Sierra Leone. As you can see, these are some of the leaders here on stage. We were honored to have the Honorable Minister of Health, Dr. Austin Demby. He joined us in today. He opened up our ceremony. The Chief Nursing Officer, the Chief Medical Officer. We had our keynote speakers. This woman right here is Dr. Patricia Abuba. She is a Sigma member, as you can see, proudly wearing her cord. She is also one of our former presidents of the Sierra Leone Nurses Association in Freetown. Very, very good woman. As you can see, these lovely students here coming, these are students that we got sponsored. So these are 5 students that we have. They traveled all the way from McKinney, Sierra Leone, from the northern area. They're nursing students at EBK University, which is Ernest Bai Koroma University, which they have a SRN program, which is a 2-year diploma program. And we want to announce that EBK is now have a BSN program. So they have a 4-year degree nursing program, and hopefully they will have advanced level nursing. And we're praying for that in the country. Next is we have some nurses who came out from Leone, and that's not close either. So these nurses traveled about an hour and a half away to come out to this conference. They were also sponsored with their nursing student, and we're so glad we had a Sierra Leone Nurse Association member chapter. Bob Jamwanda, he sponsored them. These nurses here, we had Dr. Claudette Gordon from Sigma sponsor them. We also have, these are the people in the crowd. So this venue holds about 500 spectators. And look at all these people in the sea of purple. These are our Sigma members, my Sigma members that I was honored to induct over the years from 2019. You see the venue is widely packed. There's maybe 1 or 2 seats missing out of a 500 venue. I would say about 450 people came to this event. And so this is the Minister of Health speaking, Dr. Austin Demby, who is a fellow Sierra Leonean, but he's a fellow American. He hails from Georgia. He used to work for the CDC. And when he became our appointed minister, we were elated because it's someone from the diaspora. So we're hoping that he wants to make change and do great work in Sierra Leone. I will share that we are going to actually have Sierra Leone's first ever Health Summit Week. We kicked off on March 17th, 2022. We had our pre-summit activities on the March 23rd, which is Sierra Leone Nurse Association's 61st year anniversary. And now today, Sigma Theta Tau, in collaboration with its interest group in Sierra Leone and Sierra Leone Nurses Association, which we have our membership worldwide in New York, New Jersey, Texas, DC, Maryland, Virginia, and California, which is our first chapter here in the United States, and Minnesota. And hopefully we'll have chapters in Ohio and Georgia. we're all working together. And so they collaborated to help this event be success. This event was an event that I planned in 2021 with Wanda Johnson of Sigma Theta Tau Delta Zeta chapter president. And we're so glad that we were able to execute this. I'm very honored. It's very emotional for me to see this historic day happen. And this is Dr. Demi talking again. You can see on the monitor. We want to thank our cameraman, Mr. Jallo, for assisting us with this help today, coming all the way from McKinney. And Mr. Jallo has been there since Sigma Theta Tau's first inducted member in 2020. You can see Dr. Demby here walking. That woman in the front is Elizabeth Lamar, who is the president of Sierra Leone Nurse Association, and she's also our president of our interest group in Sierra Leone for Sigma Theta Tau Delta Zeta's Sierra Leone interest group. As you see all the women in the uniform, these are various nursing students and matrons attending. These are some of our speakers that we have who are our Sigma members who are wearing our color is purple. In Sierra Leone, we call that color mauve. These are more people. This is Dr. Michael Karoma, who used to be our former vice president of Sierra Leone Nurses Association in Freetown, and he is one of our key leaders and our administrators in our Sierra Leone Sigma Theta Tau interest group. As you can see, these are some of just the presentations that they have. Again, we're hosting this, imagine, in the newly erected Freetown City Council auditorium, which is based in central center of Sierra Leone, West Africa. Again, we want to thank the Honorable Yvonne Akisoya OBE for making this happen for us. I reached out to Mayor Akisoya last year, October, telling her this wish that we want to have this huge research conference in her facility, and she was obliged and connected us with the management, and from there we made it happen. So we hope to have this, her facilitate us, and this happen every year at City Council. As you can see, more pictures here of the venue. We want to shout out the midwifery school and all these nurses and nurse students who did a wonderful skit on maternal health and just healthcare period, and how what it's like to be a nurse working with patients in our country. And they sang and they sang songs to celebrate nursing and healthcare in the country. We thank all our medical community, the doctors who presented themselves today, for the pharmacies who worked with us. As you can see, more introductions here on the screen. And this is more, wow, look at this. This is beautiful. Oh, wow. So this is some of our, oh God, this is gonna make me cry. This is some of our, this is some of our nurse students. So, being a nurse student is not only people who haven't been nurses, we have people who are nurses who want to become advanced practice nurses and midwives. And these people came from far. A lot of these people came from 3-4 hours away for this conference. And they got on stage, and I'm real proud of them. I'm sorry, guys, I didn't mean to cry. This is a presentation from the maternal health group, which they did stellar. And we just want to thank Francis Lamar for guiding us, and the midwifery school and all the midwifery school representatives, and for guiding us in the ministry. And you can see he happy on camera as they're presenting in the auditorium. You could also see the presentations for maternal health. And this is, I want to share with you guys. So this is our program chair. As you guys can see, this is Findicella. She's one of our, when we did our second round of inductions in Sierra Leone, she's our vice president. and for Sigma, and she's also the social secretary for Sierra Leone Nurse Association. A wonderful and powerful leader this woman is. You can see she is a proud, I am a Sigma nurse and very proud. This woman works hard for us. And we love you, Finda. We love you for the work that you've been doing for us. And this woman here is Sister Vicky Reed. She is a Sigma member, and she's a proud Sigma member. She hails from Georgia, and she's the director of nursing in Connaught. And this woman proudly sponsored our breakfast. She sponsored medical facilities for SLNA in the north. She has paid for matrons and nurse students to attend this conference. She came herself all the way, drove in from Connaught, and she's so proud for this event. We're so happy to know Vicky Reed. We're very thankful. She's a proud Sierra Leonean. And I just want to thank everybody who is tuning in and participating in this event. This is groundbreaking for us, as you heard up the minister's mouth. We're very, very proud. And unfortunately, even though all of us couldn't have been in the room with them, I feel their energy, and I'm getting lots of texts and calls, and I know I miss them just immensely, and I'm very proud of them, and I'm very proud to say I'm their nurse colleague. But I want people not to underrate the healthcare profession in Sierra Leone. They need to be recognized. Africa needs to be put on the map, and this is how we do it. So again, I want to thank everybody for tuning in. I know that the conference, I will start to wrap this up because the conference, we're going to end this by, we said we would end it by 12:30, 1 o'clock. So I hope everybody, the portions of the conference that you did get to enjoy, that you were able to enjoy it. I will try to share more pictures with you all. I also want to thank this gentleman here. I can't forget to thank him on camera. And let me screenshot. We can't forget to thank him on camera. And yes, everybody will see it on live stream and on YouTube. We cannot forget to thank this gentleman. We cannot forget to thank him. And so we do want to thank, this gentleman here who's been with us from the very, very beginning. We want to thank Mr. Ibrahim Sari Jallo. Mr. Jallo is an avid supporter of the nursing community. This gentleman has documented this history for this whole beginning for Sigma, from the very first certificate that we presented to Mary Makafula, our CNO. Christiana Masale was the registrar of the country as Mary Makafula, the chief nursing officer, and I was proudly able to present Betty Lamont, Elizabeth Lamont, who is the president of Sierra Leone Nurse Association, was the very first person to pay dues to me to become a Sigma member. I also want to thank some people, Adama Kamara, who is one of our nurses who was a supervisor at Aberdeen Women's Center. Adama Kamara is the reason why Sigma came into Sierra Leone. We learned about their women's center. We decided to donate to it, and President Wanda Johnson saw a video sent by her, Sister Adama, and we decided to ask her for membership. From then we had other people join us quickly, and Adama eventually joined us. But if it wasn't because of Adama Kamara, we wouldn't be where we are today with Sigma and Sierra Leone merging together. So again, I thank you all for making this happen. Thank you, Ibrahim, Sari Jallo, Mr. Quavo, for coming down and supporting us with this. It takes a village, guys, for Africa. And so we don't want you all to forget it. If any of you all on Zoom or live stream have questions, please share questions with us. Again, we want to thank the Honorable Dr. Agatha K. Bula for tuning in from Malawi, from Sigma Theta Tau. She is a Sigma Africa region coordinator, so she's the head for the continent for Sigma. And we look forward, the Republic of Sierra Leone is going to work very closely with Dr. Bula to make magic happen for the continent of Africa. Again, I thank you all. And again, you're welcome. And again, we want to thank the Sierra Leone Nurses Association for being the backbone, and the Sierra Leone, all the nurses and doctors and pharmacists and scientists and CHOs and physician assistants in the country for being the backbone behind this. Forever Sierra Leone.